not on the S drive, but they are on the website. So again, if you go on to Kansas Legislature, find Bob Bethell, and then go to Agenda and Minutes, and you will find all of the testimonies. Welcome back, everyone. It's great to see everybody out there today. I have a bit of a head cold, so if I sound like I do, it's because I do. And I took a morning cold tablet, which can make you a little droopy-eyed. So if you see me falling asleep, have Representative Carpenter nudge me just a little bit. We have a lot of good testimony today, and you will notice that committee, the 831, the responses for the third quarter are written only from all of our MCOs. At 8:32, that's why it's just a minute apart, we have the presentation from KanCare Ombudsman, and that is Suzanne Luker. And again, that is written only. Of course, we will be reading all of these testimonies. So we're going to begin with the presentation by the Long-Term Care Ombudsman, Haley Ordoin. Welcome, Haley.
Good morning. Make sure that I am okay. Am I advancing or will you be? Okay, I'm just going to test. There we go. Okay, we are good. All right, good morning, Senator Gossage, members of the committee. I thank you again for the opportunity to testify and be here in front of you once again. My name is Haley Ordoin, State Long-Term Care Ombudsman. And just as a reminder, in the slides here, you'll see the function of our office. Maybe. There we go. Okay, so up here is just kind of a gentle reminder of what we do. We are the advocates for anyone who lives in an adult care home in the state of Kansas. So that does include your long-term care, skilled nursing facilities, assisted livings, home pluses, board and care homes, things of that capacity. We are not in independent living, even if a home has those multiple level units in their home. And then included there, again, is a reminder of the functions, excuse me, of what our office does. A lot of what we do is complaint investigation. We are contacted and we try to resolve to the preference of the resident. So sometimes that's always not what the home wants, what their family wants. It's for the resident. We're there for the resident, for their voice, even if it's maybe not what most people would consider in the best interest, quote unquote, of the individual. So keep that in mind. These are also just kind of reminder slides too. I know that you guys serve on multiple different committees and you hear lots of different things. So it's always good to give you a reminder again of where we are all at. You see at the bottom, the 298 nursing facilities, over 18,000 licensed beds. Then you have the rural care facilities also. And the total homes, this was at the close of last federal fiscal year, so almost about a year ago. We're going to be preparing our next annual statement to give to you when legislature full-blown starts back up in January. But at that time, there were 802 total homes and a little over 33,000 total beds that we are here representing. Reminder too on the complaint types, this is just a breakdown of what a lot of that means. Resident rights is about half of what we operate in. So the resident rights that are in our state and federal regulations is what the majority of our time is utilized with. Abuse, neglect, exploitations, admissions, discharges, visitation, choices not being followed, those sort of things. Trying to move back to the community, the environment of least restriction of that individual's choice. So who often makes these complaints? A lot of the times it is the resident that contacts us. Over half the time, that is who contacts our office. Family, representatives, friends can contact us too. Our office, if we go in on a routine access visit and we see something, we can also open a complaint on behalf of our office. Sometimes facility staff will come to us, a lot of times want to be anonymous, and there can be others. We have had doctors. I have had some of you contact me with some complaints to investigate, can fall in that line. And then oftentimes the complaint resolution, I always put the slide in just as a reminder to everyone. It doesn't necessarily mean we weren't able to do something. What it means is we have fully or partially resolved. The withdrawn or no action needed, withdrawn is when a person passes. So if the resident passes, our complaint completely stops. The case is closed. That is relevant when we talk about the state surveyors, because oftentimes if they don't get to an investigation or it gets put on the next annual survey, which right now I believe is running at about 19 months, that case may never ever get investigated or looked at, okay? All right, so understanding time is vital and important. I have 4 main points here to just kind of reiterate that are our asks. And the beauty of testifying at other committees is that if I get homework, I come back with some answers to you guys. So we had one of our asks was the increase in the KDAD's surveying staff. There's been a lot of discussion about that. We have been advocating too for the multidisciplinary teams to try to bring in other individuals. I think there's probably more to be heard on that later today. So I'm not going to spend too much time on that one, other than we are very pro, hey, whatever we can do to bring in more surveyors to the team so that the needs of the residents are being addressed. Because a lot of what our residents come to us and say is not, hey, maybe have a little bit more leniency, things are hard. It's that we're not being heard soon enough. We feel like we don't matter. Don't even bother referring it because the complaint's not going to get investigated. That's what we are hearing. All right. Also, the expansion of the discharge reporting requirements. I understand historically this has been a hot topic. It's probably going to continue to be a hot topic. We had asked for an amendment of the language of KR 28-39-148B1 to really just kind of match what the nursing homes are required to do right now. The nursing homes are required to send the notice to our office of an involuntary discharge, so those 30-day or emergency discharges that meet the criteria listed. We're asking for that to expand to the other provider types that fall under adult care homes in our state, so like our assisted livings, home pluses, things like that. Because what we find, and I know that I think in January it's supposed to be reported back to you by KDADS. KDADS is kind of tracking that. It's supposed to be self-reported from these providers to KDADS, and we're already seeing inconsistencies. KDADS has been very forthcoming to us about that reporting and that information, and we are getting reports to our office from the residents that does not align and match with KDADS. So we are concerned that there is some inconsistency of self-reporting, that if there was requirements for those homes to report that to us, we can get in, we can try to resolve. And a lot of times we can. A lot of times there's been issues such as a power of attorney, guardian, or family member not paying a bill, and that is a qualifiable reason for discharge. We are able to resolve those. So we're working hard for those residents, but we can't address issues we don't know about. All right, next one, the pharmacy provider choice and fees. This was something that many of you were pretty passionate about, as are we. And what this is, I'm gonna go to the next slide just to kind of show you an example of what we are seeing. We are having residents contact us stating that if a individual, and it's private pay individual, not Medicaid, because they cannot charge this to Medicaid, but a private pay individual chooses a pharmacy that is not the facility's preferred contracted pharmacist, and they get their medication through them, excuse me, sometimes the VA is included in that. The homes are charging anywhere from, we've seen $150, $100, all the way up to $300 per month to use that pharmacy provider of choice. They'll say it's an administrative setup fee. This is a sample letter from a home. And I'm not out here to make too many enemies, so I did delete out the home that this letter was from, but this is reference for you to see of kind of how that's worded. So our ask was to do something about that. Well, We weren't sure where to start. I started talking to several of my colleagues across the country, and it turns out North Dakota has already started taking action on this. And what they did is that they amended their state regulations, and that link at the bottom will take you directly to their regulations of how it's worded. But I took out that section there, the right to a pharmacist of the resident's choice, irrespective of the type of medication distribution system used by the facility, and to not be charged a fee or receive a financial incentive or disincentive for choosing a pharmacy other than the facility's preferred pharmacy. They also included the extra line of the resident may not be charged for repackaging if that cost can be included on the facility cost report. So they had made some amendments. Then they saw the facilities were kind of doing a few different things to kind of work around that. So they included that language too. That would be our recommendation for where we start of how we start addressing this. Because the longer it goes on month by month, it can be pretty substantial, and that's what we seem to be experiencing. I am not sure what happened there, sorry. Trying to address this, advance the slides here. Excuse me. Technical issues. All right. Well, I'm going to start talking because I kind of remember my next slides, and that is on the personal needs allowance. That was the next ask that we had, was to increase the personal needs allowance by about $10, take it from 62. Thank you so much. God bless America for IT. All right, there we go. All right, was to increase that personal needs allowance. And I included this slide to show you where we fall as a state compared to the rest of the country, okay? We fall kind of right in the middle, around 26th. The range across the United States is anywhere from $30 to $200 per month. And I know the homework that I had was what is gonna be the financial impact of that? And I apologize, I don't have it in the slide up here. Testimony was due before I was able to get responses. But I did reach out to KDADS and to KDHE, and KDADS came back and gave me information that they had presented in previous Bethel testimony about the monthly average of individuals in nursing homes that have Medicaid or that are on Medicaid. So in state fiscal year 24, the average number of individuals on Medicaid in nursing homes was a little over 9,000. It was 9,173. And then they had the first 3-quarter information available to me, and it was a little bit more, about 9,200. So you can kind of see the impact of, we're asking for the $10 difference, so that makes math, a little bit easy. So you're looking a little over 1.1 million annually, seems to be about the average of what that impact would be. But we would make that recommendation to increase the P&A to $72 and then tie it to the annual COLA. So hopefully I made that short and sweet and very forthcoming with our asks. I will say I understand in previous committees that when we asked for the expansion of reporting requirements, I know that some things had come up, or some other individuals and groups were had some concerns or were opposed to that. My understanding is Leading Age had reached out and said that there were some concerns about that. I did reach out to their office, and to date, I have not heard anything back. Please hear, we do want to be collaborative, so we would always welcome that if there are any concerns about what the expansion of the reporting requirements how it would be problematic to anybody. So if we can work together, we're happy to do that. But with that, I will stand for any questions, and I thank you all for your time.
Representative Carpenter.
Thank you, Madam Chair. And so, Haley, thank you for that. And as you know, at the last interim committee, I did have some concerns about that. So what would be the downside for the nursing homes, the state-operated ones? What would that entail? A lot of more paperwork? What would be their opposition to that?
So the state licensed only homes that are not currently reporting to us, as long as they're not discharging someone on an emergency basis very frequently, which shouldn't be. I think this last year, according to our annual report, we had about 68, 70 annually that we were made aware of. It would be reporting those as they come about, and then all other homes would then, if they're following the federal requirements, which the nursing homes are already, they send us an annual report of, or not an annual, I'm sorry, a monthly summary of discharges that we, review. So it really, in my opinion, it shouldn't be that cumbersome as long as they're not discharging people completely left and right. It's once a month reporting or as the need arises. And we are working, part of our hopeful 3-year plan with IT is to get an actual reporting database system. KDAD's already has some infrastructure. Some other states already have the algorithms and stuff that is not my forte, that we can replicate and duplicate to make it an easier reporting system. Because I realize that if we're going to start asking people to report, the easier we can make it, the better. So I don't see it being an additional burden. I'm happy to discuss with them otherwise, though, if they feel that it would be.
Thank you for that. That's one of my major concerns is creating, more regulation and more regulatory nightmare than they already have. So that would be my major concern with that.
No, I'm not looking to do anything for anyone that takes away from patient care time.
Very good. Thank you. Thank you, Madam Chair.
Additional questions, committee? Yes. Representative Bueller.
Madam Chair, Haley, is a similar, or along similar lines as Representative Carpenter. Have you got any pushback from any of the nursing facilities on the pharmacy provider choices and fees? I'm curious. I shouldn't say have you. What type of pushback have you received?
I haven't had any come to me yet to address it, so I will.
Any urban legends that you?
I would say, having been in that situation, and I think that's kind of a blessing to this role, is that I've been in those shoes. I lived it majority of my life, so I can get where people are coming from with their concerns. I do understand that when a home, when an individual, when a resident does not use a preferred pharmacy, it may come in different packaging, it may come in some different things. I get that. I get that it can take a little bit of setup time, but also, if you're doing your medication administration correctly, you should be checking that in the first place to make sure you have the right resident, the right medication, the right dosage, and so forth. So are they doing additional of what they should be doing already? No. Can it take maybe a little bit more time of the means that they're doing it now? Yes. But does that mean it should be charged to a resident of $100 to $300 a month? In our opinion, no, because it does create a disincentive for them to utilize their own pharmacy. And I have not, excuse me, I think we might have the same thing here. I have not talked to, a lot of the pharmacy associations, trades. I have talked to some local pharmacies, and it does put a hindrance on them. It's really, creating an issue where they are losing some of their longtime customers that they have. And so it impacts some of the small rural communities like where I'm from in creating a burden.
Okay, thank you. Thank you, Madam Chair.
Additional questions, committee? Yes, Representative Rice.
Thank you, Madam Chair. Thank you, Haley. I'm just tagging on with Representative Bueller here. If my math is right, $200 or $300 per patient per month on a, say, 100 patients, that's $20,000-$30,000 a month, which seems extraordinary. I was wondering about the incentives for that. Is that just, do you have an opinion? Is it just a revenue stream for the facility, or is there some kind of contractual relationship with the pharmacy where the nursing home may be getting incentives, financial incentives from a pharmacy to have just one, or I don't even know if that's legal, that kind of kickback, but is that playing into it? I'm just wondering about the incentives. Is it just purely, nursing home wants $20,000 or $30,000 a month extra, or is there something else playing into it? Thank you.
In my complete opinion, for what it is worth, since I was asked, it does seem to come across that, because you're not hiring additional staff to do what you're already required to do and required to provide. So it's not like they can say, oh, we're bringing in additional staffing for this need. It does appear that it is an additional revenue stream. And just like you had stated, our office had kind of done that math too. If you even have, 10 individuals in that home and say you're doing, $200 a month, you multiply that home. If you have a larger corporation, you have multiple locations in the state. I mean, it's easy to see how some of these homes that are doing this can bring in an additional $1 million of revenue annually.
Just a quick follow-up, but as far as you know, there's no financial incentive from the pharmacy. They have contractual relationships where they receive money for using them as the pharmacy of choice. Is that kind of relationship legal or in effect?
I have not ran across that yet.
I have a quick question before we move on. And the very same thing is what happened to my mother when she moved from independent living to assisted living, that they chose the pharmacy rather than the one we had chosen before. But part of the reason was we had them in a local pharmacy prepackaged and brought one day at a time. It wasn't necessary for them to do that. We had to pay more for that. Wasn't necessary for the facility to do that because they were dispensing them there. So I guess I would want to know, to follow up what was said by Representative Bryce, why are they doing this? What is the incentive? Why would a senior want to keep the pharmacy that they currently have? Are there drugs at a lower price with that pharmacy? And before we just immediately start saying to a facility, you can't do this, I would like to have some more information if you could get that together for us, Haley. The other question that I had was regarding the P&A, the personal need allowance. I think median is important here. We have average from 30 to 200, but when you draw the median, there are 25 below us and 25 above us of states when it comes to that $60. Additional questions, committee? Yes. Representative Ballard.
Thank you, Madam Chair. Only because of someone asked me a question I couldn't answer, I'm asking you now. When you say your pharmacy of choice, do they always have a choice? Or there are some nursing homes that use specific pharmacies, so therefore they end up having to use them? Then to me, that's not a choice.
So the resident rights state that they should be able to choose a provider of choice. Okay, so that can mean pharmacy, that can mean therapy, that can mean, physician. So the resident right is to have the provider of choice. The home does have to contract with a pharmacy in the events of, emergency deliveries, emergency medication. So they do have to have a contract with a pharmacy. But where it gets taken away is disincentives, things like that, like what we're talking about, where they're not able to have that choice honored. Does that answer your question, or do I need to further
Yes,
explain
it does.
anything?
It says in a way you don't have a choice.
It seems to take away the choice when there's a financial disincentive tied to it. We have had residents come to us and say, I'm not able to pay that $150, $200, $300 a month. I need it for other things. It's either have my meds from this pharmacy or have, money to spend for my internet or, what have you, so that I can have outside communication.
So is there something in the policy or something they signed that says that the nursing home has that right to do that?
That the nursing home has the right to, there's nothing right now to prevent them from doing so. I reached out to the Attorney General's office. There's nothing on the consumer protection side. There is not anything currently that we have seen or the AG's office has seen or state regs state that prevent that from happening.
Thank you, Madam Chair. You've answered my question.
Thank you. Committee, we're over just a little bit in time, but we have 3 questions in the queue, and we're going to go ahead with those questions real quickly. Representative Reese.
Thank you, Madam Chair. Just to ask a little bit further of what Senator Gossage was talking about, when you think about the different levels at a nursing home, right? We're looking at assisted living on through like memory care. It covers all of that. Is that
For
for the pharmacy?
yes.
Yeah, because that's interesting, because with assisted living, I mean, a lot of people don't need medication assistance. They need assistance in other ways, so they can handle their own medication.
We have ran into a few assisted livings. I will say the majority of it is on the nursing, the long-term care, skilled, memory care side, but we have had a few assisted livings.
Thank you.
Representative Sutton.
Thank you, Madam Chair. Following up on Representative Bueller, it kind of sounds like there might be an urban legend, though, when I saw that the added language of the repackaging fees. Tell me about the discussion that went on before adding that in.
So a lot of other homes in other states, what they had ran into was they addressed the issue of, okay, you can have your pharmacy of choice, but then different pharmacies do different ways. Some might have, you know, the daily bubble packaging. Some might have your monthly cards. So then they were seeing that it went from, okay, you can have the pharmacy of choice, but now we're having a setup fee to set it up to our type, or making a requirement that it has to be in a different type of bubble packaging. You can have your pharmacy, but it has to be packaged our preferred way. And then the fee was then changed from a setup fee to a repackaging fee.
Okay, so the boogeyman is existing, but it's in other states, not here yet.
No,
what I'm getting
we
at?
run into both.
We've run into that too.
Yeah, the monthly fee is if it's the letter that I previously had up, and it's, you have it in testimony,
Right.
does state that it's preferred pharmacy and repackaging or repackaging. So we run into both.
Excellent. All right, thank you.
Senator Erickson.
Thank you, Madam Chair. Thank you, Haley. Real quick, you're advocating for the PNA to have a COLA adjustment. If we'd have had that in 2015, what would that $62 be at now? Do you know?
That's a great question. I don't know my math off the top of my head. I would have to report back to you.
I did a little quick math here. Check me if it's right, but it would be at $84.30.
Okay.
So, and if you notice on your chart, a lot of the states that have over $100 do have the COLA. So just to point out, you know, that would be a substantial increase just for the committee's attention. So, thank you, Madam Chair.
Haley, thank you so much for being with us today. Committee, we're going to move on to our next presentation, which is the Office of Medicaid Inspector General, Steve Anderson. Thank you for being at the committee. Please proceed.
Good morning, Madam Chair, members of the committee. I'm Steve Anderson, and it's always a pleasure to come before this committee and talk about the Inspector General's office. Just want to share with you the number of complaints that involve fraud, waste, and abuse continues to grow each year. Last year, we processed 1,454 complaints. This year, we're already at over 1,221 complaints. That's 115 complaints higher at the same point as last year. In my testimonies included a chart that has a outline of the various audits that we've completed, and the most recent one I'm going to talk about, and that's the MCO prior authorization audit. I do want to point out on that audit, before we get too far into it, that you'll see on the chart, there's no waste identified, there's no overpayments identified, there's no savings even identified, but there are 17 findings and 42 recommendations. The point I want to make with that is not every audit results in savings, waste being identified, but they still matter. The people out there that were audited and the people who are taking the results from this audit, it's meaningful to them. So my office is not always going to return money to the Treasury or identify waste and what have you, but it still matters. So on to the audit. The prior authorization audit was requested by KDHE. We did this involving the managed care organization's prior authorization process for Medicaid recipients. And we published that audit on October the 2nd of this year. Everybody in this room should have gotten a copy of that audit. I don't know if you've read it all the way through. It's quite lengthy. But nevertheless, I see Senator Erickson may have a copy in front of her. Yes. So it's good reading, but it is long. I certainly appreciate that. But we always ask questions on our audits and the objectives we have. And the first one is, are there any delays in the peer-to-peer review process under each MCO? And we found that yes, there are delays. The peer-to-peer process can take up to 7 business days. that depending on the MCO resulting in delays to critical care. High rates of prior authorization denials resulted in additional peer-to-peer reviews, placing an administrative burden on hospitals and physicians, causing further delays. One MCO reported over 50% of their prior authorization requests resulted in denials. We found that many hospitals had to hire additional staff just to deal with this issue. And then the second question is, are Medicaid beneficiaries being placed in observation status when they should be classified as an inpatient? We found that, yes, that was the case. Patients are defaulted to observation status when they're admitted to the hospital. MCOs appear to be using commercially sold interqual or Milliman care guidelines, and otherwise known as MCG, criteria to deny inpatient status and keep patients in observation status despite them meeting medical standards for inpatient criteria. And then third, is there a consistency in how each MCO determines the level of care for post-acute care? No, there's no universal standard or federal requirement for how MCOs determine level of care for post-acute care. The MCO's individual determination processes are not available to the hospitals, and post-acute care claims are often denied without explanation. Some issues that we pointed out in the executive summary was talked about conflict of interest. It was discovered that one of the MCOs owns the clinical criteria screening tool for prior authorizations. So we have a KanCare MCO using their own clinical criteria screening tool, potentially creating a conflict of interest. Having control of the design, logic, and algorithm of how the associated with these criteria provides the MCO an opportunity to potentially abuse the cost containment strategies for the purpose of maximizing benefits and to boost performance metrics. Additionally, hospitals also indicated they employ a claim review service provided by Optum or Change Healthcare. It turns out that these services are used to apply the correct coding initiative edits to verify the claim coding aligns with the Kansas or with the KMAP requirements. However, both Optum and Change Healthcare, the ones who are used, are also owned by the same hospital or same group, and that's United Healthcare. Then we also looked at delay and denial of medical and necessary levels of care and post-acute care. Hospitals reported that MCOs are delaying responses for post-acute care, prior authorization request, sometimes resulting in the patient being discharged without the needed prior post-acute care situation. Hospitals often times wait up to 14 days for these responses, extending stays and delaying discharges. Hospitals frequently change the prior authorization request to observation status to increase the likelihood of approval. The delays in the post-acute care prioritization also reduces hospital bed availability, leading to longer wait times for ER patients and hospital transfers. Some hospitals report that their facilities are full of patients that they can't discharge, which will show them as a full status. MCOs frequent deny of hospital readmissions within 30 days, even if the admission is unrelated. I think this is interesting. The MCOs issued readmission denials when patients with similar diagnoses are readmitted within 30 days, citing administrative denials for admission. These denials occur even when the patient's condition necessitates readmission. Hospitals report that MCOs frequently deny requests for long-term acute care hospital stays or placement, steering the patient toward lower cost post-acute care options instead. These denials often lead to preventable hospital readmissions, which the MCOs then refuse to cover. Additionally, MCOs frequently reject admission claims within 30 days of discharge, even if the subsequent admission is unrelated. This causes the hospital to lose money when claims associated with readmission are denied. That's the MCO audit. Another audit that we've recently undertaken, is titled the HCBS 2 audit. For those of you who've been around very long, you recall we did an audit on HCBS program or home and community-based services back in 2022. This is a follow-up audit that many people ask us to perform. And we're looking at how the program is managed by KDADS as well as KDHE and the MCOs. The questions we're going to ask are, do HCBS waiver beneficiaries consistently receive at least one service per month as required? That was an issue we'd previously identified. Are HCBS beneficiaries redeterminations tracked effectively to ensure compliance with program requirements? As you may recall, they're required to have a functional assessment every year. We're looking at that. And then our HCBS waiver wait list effectively managed to ensure equitable access, consistent prioritization, timely removal, and compliance with federal and state regulations while mitigating potential conflicts of interest. Fourth, are functional assessment invoices adequately evaluated and verified before payment is issued? And then are the quality assurance checks conducted by KDADS through designated quality management specialists effective and reliable at ensuring compliance, accuracy, and accountability to service delivery? The next audit we currently have underway is the DCF KDHE data sharing audit. This performance audit is looking at the sharing of eligibility data between DCF and KDHE. Our audit will look at the Medicaid and SNAP assistance program eligibility data from July 1st, 2024 to present, and we'll seek to answer the following questions. Does DCF and KDHE review data collection pages and image documents that are housed in the shared Kansas Eligibility Enforcement System, otherwise known as KEYS, to determine if reported eligibility information is accurate? Does DCF and KDHE maximize system sharing capabilities to alert each other when there is a status change with a mutual member that could have a direct impact on eligibility? What policy and procedure and policy changes are needed to take advantage of available data? Another audit we just kicked off is the pregnant woman eligibility audit. This audit will also look at the pregnant woman program, and we'll be looking to see, are there people insured under the pregnant woman program that are not eligible per pregnant woman eligibility standards? Do pregnant women beneficiaries have pregnancy-related claims that confirm their pregnancy? Are there beneficiaries being transitioned from Medicaid's pregnant woman program to appropriate Medicaid program per eligibility standards if they are eligible? Then we're also looking at the pharmacy dispensing fees. This was something I didn't know anything about until we started this review, is that they're dispensing fee for over-the-counter medications. So we're looking at that, and we're seeing how that money flows through the PBMs. We're finding out that the PBMs are scraping some of this dispensing fee, but there's a $10.50 dispensing fee on over-the-counter medications that are written on a prescription from doctors to pharmacists. So for a $3 medication, we end up paying the $3 plus the dispensing fee of $10.50. But we've learned that the PBMs are getting quite a bit of that money. It's not actually going to the pharmacy to pay them for their level of effort. So things we're looking at, what's the dollar amount the state of Kansas pays in dispensing fees for over-the-counter medications? How many over-the-counter medications or prescriptions are being filled each year by Medicaid? And what medical providers are prescribing Medicaid beneficiaries the highest number of over-the-counter drugs? Just want to talk, we did an issue brief. You can see it in my testimony. We're trying to do an issue brief on various topics every month, and we just did one on KMAP and found some problems with accuracy in the document, but we're working with KDHE to get that resolved. And then investigations, we currently have 7 state-level investigations and 2 federal-level cases that have been accepted for prosecution, with numerous other cases in various stages of investigation, including providers and state of Kansas employees. The loss for these cases is almost $500,000. One case involves a person that assumed the identity of their deceased cousin to receive government benefits under both identities. With that, I'm more than happy to answer questions, and thank you for your time.
Questions committee, Representative Sutton.
Thank you, Madam Chair. One thing that you mentioned there kind of raised my eyebrows because I'm not exactly sure of the mechanics on this. You mentioned that the PBMs are taking the dispensing fee or some portion thereof, the dispensing fee. I was under the impression that the dispensing fee went straight to the pharmacy. Where does the PBM get involved in that transaction that they would be able to take some of the dispensing fee?
We're still working on that, Representative Sutton. We were surprised to learn that as well when we were doing the reviews of the data and how the money was being transferred. And of that 1050, seems that most of it does not make it to the pharmacy, but rather gets scraped off by the PBMs. But our auditor's looking at that, trying to see how they're doing that and what the process is for. That's still preliminary, but it is showing that oftentimes the money never makes it to, or very little of the money makes it to the pharmacy.
Seeing as how it goes straight to the pharmacy, I'd be very interested in seeing how that happens.
Bear in mind that anything with Medicaid takes a very long route. It has to go through the MCO, then down through the PBM, then to the pharmacy. So it doesn't go straight to the pharmacy. It goes through a route because the pharmacy bills Medicaid, it goes through the MCO, and then the payment comes back through the PBM.
Right. I thought that the dispensing fee, though, was pretty clear and labeled as, I know money's fungible, but nonetheless, I was under the impression that that was highlighted as going to the pharmacy. So I'd be very interested in seeing what the auditor comes up with on that.
You bet.
Thank you.
Representative Ballard.
Thank you, Madam Chair. Representative Sutton asked a question that I wanted to, and according to a pharmacy, they do not really see it, and if they do, it's minimal. Okay, so it's a problem. But would you elaborate a little bit more on the pregnant woman program? I wasn't sure exactly what you're looking for or trying to stop.
Sure. No, what we're looking for, we know from some prior investigations that we've had people that have claimed to be pregnant when in fact they were not, for the purpose of getting on not only Medicaid, but they also get on SNAP, TANF, other programs. And it's very easy in the state of Kansas because of self-attestation. If you say you're pregnant, you're pregnant. It's that hard. So one of the preliminary things we found was we have an awful lot of women who are 46 and older in the state of Kansas that are claiming to be pregnant. And when we look at their claims, there's no associated claims that perhaps a woman who is, and we've had some as old as 60. If you're 60 years old and you're pregnant, you're going to go see a doctor, I'm guessing. I don't know that for sure, but my wife's 61 and she assures me that if she was pregnant at 61, she'd be going to see a doctor. So. I hope that answers your question.
Yeah. Yes, it does. But, excuse me, I'm sorry. But I want to back up just a little bit. You have to have an application to fill out. So if I say I'm pregnant, do you not need proof?
No. State of Kansas accepts self-attestation. They have that approved through CMS to do that.
Presumed eligible?
Yeah, they basically take your word for it. If you say you're pregnant, you're pregnant.
Okay. Well, then, no, I understand that. I thought at one point you have to have proof. If you, no, but you don't have to have proof at any point?
Nope, they can question it if they have good reason, and that's one of the things that we're looking at is to see if they ever do question these geriatric pregnancies, to see if they question it. But from what we have seen so far, there's no questioning of somebody who it might be dubious. One of the investigations we have under right now, the woman is 42 years old, not in this group, but she claimed to be pregnant. And the fun thing is the state of Kansas through Medicaid paid for her to have a sterilization about 4 years before that. So that was in her record. I mean, if the eligibility worker had looked back in her file even a little bit, they would have seen that she had had a tubal done. So it would be highly unlikely. And again, if you are pregnant after having a tubal, you're definitely going to go see that doctor.
Yeah, you sure do. Thank you. Thank you, Madam Chair.
Senator Petty.
Thank you, Madam Chair. My question actually goes back to the, with the pharmacist issue. I was wondering, what exactly will the question, got sidetracked with the pregnant women, thought 9 months would actually answer one of the questions. When the last one, which medical providers are prescribing Medicaid beneficiaries the highest number of OTC drugs, I'm a little fuddled here on what does that answer?
What does that answer for us? We're just trying to see if it is a situation where if it's being done a lot by APRNs or if it's medical doctors or who's doing the heaviest prescribing. We've heard a few things that it's a lot of APRNs. We're just trying to verify that. That was something that had been presented to us by somebody to raise that as a concern. So we're just trying to verify that was indeed the case or not.
So you'd be looking at just in the last couple of years because.
Yeah, within our audit period.
Yeah, because APRs hadn't, and wouldn't that also have a little bit to do with the population they work with?
Sure, and we'd take allowances for all that, absolutely.
Thank you, Representative Ruiz.
Thank you, Madam Chair. Thank you for the presentation. On this, the over-the-counter, I have a couple of questions and a couple of asks, actually, for you.
Okay?
So we're looking at over-the-counter medications that are prescribed by a prescriber, and you're going to specifically look at MDDO or APRN. And look at my notes here. So I'm wondering which prescriptions, what kind of medications those are, the over-the-counter. Is it aspirin? Is it
Yeah.
whatever?
You know what kicked this off is during a recent Bethel meeting, the Healthy Blue representative testified that their #1 prescription drug was ibuprofen.
Okay. So is it possible for you to give us the name of the drug that is being prescribed?
Of course.
Okay. And like a tally of that?
You bet. Yeah, we intend to do that.
Okay. And then I know you're going to look at the cost to the state
Yes.
with that, right? I would be curious, I don't know if you can do this, to see if we did away with the tax on, sales tax on over-the-counter medications. We've looked at different bills for that. It doesn't seem to go anywhere. But I'm wondering about what kind of savings could we have to the state if we would simply do that?
Sure. So you're requesting that when we calculate the cost, if we look at what the sales tax that were gathered on that and have that broke out as a separate line item. Yeah, we can do that. I'd be
Fantastic.
glad to do
Thank you
that.
so much.
Representative, or I'm sorry, we're at Senator Erickson.
Thank you, Madam Chair. Thank you, Stephen. Always appreciate you and your team. Going back to the prior authorization audit that you did, the dates covered on that are January 1st of 2021 to December 31st of 2023.
Right.
Do you know with the new KanCare 3.0 contract, do you know if any of these issues have been resolved? The hospital laid out basically hospital association, 4 major categories. Do you know if any of those have improved with the new contract or not?
I can't say for sure. I know, KDHE responded, and their response is part of the audit. And, they agreed with a lot of our findings and made recommendations, but there doesn't appear to have been anything that would have changed any of this as a result of 3.0 starting. But it did give them some ideas for 4.0, perhaps.
Okay, thank you. And I hope we get to dig into this more in government efficiency next week.
Of course.
Thank you.
Representative Carpenter.
Thank you, Madam Chair. So I guess when we talked about that, we put presumed eligible in our statutes, I don't know, it's been 4 or 5 years ago. Who would have ever thought that anybody would take advantage of that? I mean, it is just bizarre to me to hear that and why we did it was a lot of times if these folks, they are with our pregnancies under KanCare or Medicaid are well over 40%, it was a cost savings for us, for those folks to receive care because if they couldn't afford it and there was an issue with the babies or anything like that. So maybe we should put a time frame in there within 3 months of their presumed eligibility that there is a pregnancy test. I think that'd be a good thing to start out with. Again, I'm just shocked at how people take advantage of it.
Yes, sir. You might find this interesting. And one of my staff members was at a conference and was discussing this with California. And the California people out there said, you take self-attestation? We don't even do that. And that was California. So.
Senator Peck.
Thank you, Madam Chairman. On this, this is amazing to me, but on the pregnant woman or man, as some people would say, if a woman is indeed pregnant and qualifies for Medicaid and SNAP, participates in the programs, but then later has an abortion, which ends the pregnancy, would the audit or would it be known that this woman had an abortion, so she's really no longer eligible because of being pregnant?
We're not focusing on that to be sure, but we do understand that if after an abortion or a miscarriage or anything like that, continuous eligibility, postpartum care that women are entitled to will continue on for the I think it's a year following a delivery, for example. So if there's a miscarriage or abortion or anything like that, they would still continue to have some coverage under the program because of that, because it's an ending of a pregnancy, whether through abortion or through natural delivery or a miscarriage.
Thank you.
I have a quick question. I know we're running out of over time. We've been hearing a lot in the news about the SNAP program, and I know part of what you were reviewing was eligibility for SNAP. Can you just help us understand, we'll probably hear from the department in a little while, regarding the federal requirements, and is that any different than other requirements that have been made regarding federal assistance?
If I understand your question, Senator Gossage, the requirements between Medicaid and SNAP do vary, depending on household, who's in the household, the father of the children, the parentage. There's a variance in those. I've talked about this in front of other committees, that we know that people will tell a different story to accentuate their benefits under SNAP, and then they'll tell a different story to accentuate their benefits under Medicaid. So what we're looking at is those two programs, because the KEYS system houses both sets of data, and it's right there to look at if you just look. So we're wanting to verify that, because it would be really nice for eligibility workers when somebody says, for example, that somebody's not in the household, or that the father, this man that's in the house is not the father of the children, but then on the other panel or other set, they declare that they do. Also, incomes adjusted in there. So we're just wanting to look at that data, and that's the big issue.
I don't know who that could be, but they need to turn their phone off.
Yes, it's a very important call.
And it says scam likely. My apologies, committee. I thought I had my sound turned on. Don't I know it?
I think that's Mrs. Anderson saying, thank my husband for revealing my age in committee. I think that's what that called.
I do have that in a text, by the way. So a follow-up question on that then. So two things is that the federal government is requesting information on the SNAP recipients. Do you feel like that this is out of line? Is this out of the ordinary from what they usually request?
Well, we know that they look at the eligibility or at the data that's used for determining the error rate. And this would actually, our audit would actually is going to be looking at error rates to see if there's a variance in it. We could help them with that error rate, because Kansas's error rate, the biggest issue is over payment, right? It's a very small amount of it's underpayment, and a lot of it's overpayment, and this would help do that. So the federal government's wanting to look at the error data. I get that. I mean, they've been sending letters to the state of Kansas over the past few years saying your error rate's way too high. So I understand their desire to look at that, and that's one of the reasons we're wanting to look at the data. And but again, I've been talking about this for the past couple of years, ever since we started thinking about we were going to have responsibility to look at some of the SNAP information. I've been thinking about this. So this has been something that's been the hopper for us for quite a while.
Thank you so much for your report today.
You're welcome.
Committee, we're going to move on now to the presentation of the Kansas Legislative Division of Post Audit and Karen Osterhaus. Welcome, Karen.
Thank you, Madam Chairman, woman,
Well, it's Katrin.
and members of the committee. My name is Katrin Osterhaus with Legislative Division of Post Audit. Matthew Fahrenbrook also conducted this audit with me, and he is joining us on WebEx online, I believe. I'll be presenting our limited scope audit, in which we evaluated the results of the Office of Inspector General's audits and investigations work between calendar years 2021 and 2024. This audit had one question: how much state general funds has the state recovered due to the direct work of the Office of Inspector General, and how many of the office's investigations have resulted in a prosecution? In short, we found that the Office of Inspector General's work between calendar years 2021 and 2024 has resulted in 2 prosecutions and the recovery of $1.3 million in federal and state funds at the time of our audit. So to unpack all of this, and I believe you do have the online audit in front of you, I'll cover first a little bit of background information, and that information starts on page 3 if you do follow along. Kansas offers 3 main medical assistance programs to eligible residents. First, Medicaid. Of course, that's the joint federal and state program providing health coverage to certain low-income groups. Second, there is the Children Health Insurance Program, again, a joint federal and state program providing health coverage to uninsured children who do not qualify for Medicaid. And third, Medican, a state-funded program that provides a temporary health coverage to individuals applying for Social Security disability benefits. The Kansas Department of Health and Environment is the primary agency responsible for administering those programs. However, the Office of Inspector General, or OIG, plays a role in this oversight. In 2017, the legislature has established the OIG as an independent office within the Kansas Attorney General's office. It was previously part of the KDHE, but had been inactive since 2014. And the OIG reopened in 2019 with a new Inspector General. The current Inspector General was confirmed in April 2021. The Office of Inspector General now has 10 staff members and is responsible for audits, reviews, and investigations to ensure accountability and integrity for the programs it oversees. Between calendar years 2021 and 2024, the OIG published 5 audits, 3 performance review reports, and 1 interim audit covering various medical assistance programs. Additionally, the OIG screened over 5,500 complaints and opened 280 investigations during that time. Most of the complaints came from the Kansas Department for Children and Families. Other complaints also came from OIG's hotline or from other agencies, law enforcement, or individuals. In this audit, we reviewed all 9 audits and reviews that the OIG conducted during that time frame and to identify confirmed monetary recoupments, excluding unrecoverable funds, and projected savings. We interviewed the OIG officials and examined supporting documentation, including materials from KDHE. For investigations, we analyzed the OIG's case list, verified the reliability of the data, and reviewed records for cases that involved prosecution or financial recovery. Now I'll discuss the findings, beginning with the OIG's investigations on page 6, figure 2. From 2021 to 2024, the OIG reported, as I mentioned, opening 280 investigations. At the time of our review, 59% of those investigations were still open with no results yet. 25 were closed without any action because the allegations were either disproven, lacked sufficient evidence, or involved losses too small to pursue. 9% were referred to other law enforcement or regulatory agencies. And the remaining 8% of the investigations, the OIG data showed that authorities had taken some form of action, such as removing ineligible benefits from the program roles or pursuing prosecution. At the time of our work, 7 investigations had been referred to prosecution, and 2 of those investigations had been prosecuted. Skipping ahead to page 9 now. The 2 investigations that I have mentioned that had gone to prosecution had resulted in the state recouping less than $1,000. One case involving a defendant who misreported their household income to qualify for Medicaid and received services valued between $25,000 and $100,000. In 2023, that individual entered into a diversion agreement requiring $2,500 in restitution and $642 in court fees. However, court records show that the defendant stopped making payments in May of 2024 after submitting about $920. A hearing was scheduled for this August to consider revoking that agreement, which could lead to increased restitution. The second case involved an individual who forged documentation to falsely claim a pregnancy to qualify for Medicaid. In April of 2025, the individual agreed to a plea deal requiring $5,042 in restitution, which was the estimated benefit at that time, plus additional court costs. This deal was approved by the court in June. Now I'm going to return back to page 8 to discuss the other part of this audit, which dealt with the audits and reviews. So based on the scope of the audit, again, we focused on funds that OIG identified as having been recouped by the state. We identified one report published in September 2021 that documented the recovery of about $1.3 million. The report found that KDHE had paid about $1.3 million to 4 managed care organizations, MCOs, between 2015 and 2020 to 25 deceased beneficiaries. The report noted that after OIG's review, KDHE was able to recover the $1.1 million of overpayments by docking payments for 3 of the 4 managed care organizations. The remaining $171,000 was recovered through direct payment from that 4th MCO, which was no longer working for the state of Kansas at the time. We reached out to KDHE, and they were able to provide data confirming the full $1.3 million was indeed recovered. It should be noted that the $1.3 million in recouped fees likely include a mix of federal and state monies, since Medicaid is funded with roughly 60% federal and 40% state dollars. OIG also identified about $3.2 million in potential future savings and about $320 million in wasted funds resulting from their work. For context, we provided this information as an overview in the figures starting on the bottom of page 10. However, we did not evaluate the validity or accuracy or reliability of that information. That simply was not part of the scope. We did not make any recommendations to OIG, and that concludes my presentation. I'll be happy to stand for questions.
Thank you. Questions, committee? Representative Carpenter.
Thank you, Madam Chair. I appreciate your work on this audit. Did you look any farther than the 3-month look back that we have for our MCO contracts?
So this was an audit on what the OIG had done. So we are not really doing anything in addition to looking at what their product is and then evaluating that. So there was no look back type situation for us.
Very good. Thank you for that. Committee, you know, our contracts, our MCO contracts only provide for a 3-month look back. So anything that happens prior to that and we find it, we don't get recouped for it, which is a concern of mine. A lot of times when you have an investigation, it takes over 3 months to find out what's going on. And I think if we look back farther than that, we would see way more than $1.3 million. But we're not able to do that because our contracts only provide a 3-month look back.
Additional questions, committee? Senator Petty.
Thanks for this audit. On the look back on with that $1.7 million, was that, I mean, I know you were looking at the office of the, that you were, I don't know if this was part of the audit or not. Was this already in the process with KDHE? Were they already dealing with that, or was it brought about because of the investigation that was coming from the Office of the Medicaid Inspector General?
I believe it was the result of the audit that caused KDHE to go and get that recoupment, but I'm sure that the OIG is in the room so they can clarify.
Thank you.
Senator Erickson.
Thank you, Madam Chair, and thank you for this. I've probably read more audits and reports than most legislators have, and I just pulled up one because I'm familiar with how the Office of Inspector General works. And if you've read a lot of their reports, I just pulled up one randomly. This is report 23-01. I'm on page 40. And here's usually what happens. Observation number 3, audit finding. According to the U.S. Department of Health and Human Service Office of Inspector General, Kansas made capitation payments for beneficiaries who were concurrently enrolled in a Medicaid managed care program in 2 states. So the Office of Inspector General finds this. And the total is there are the number of people currently enrolled in Kansas in another state in this 2023 report was 10,118, meaning that we were paying over $6 million. This is one random instance. There are a lot. So if you look at the recommendations, because the Office of Inspector General then makes recommendations to the agency, and here's where the problem occurs. The Office of Inspector General has no authority to recoup that. They point this out and they say, we recommend you recoup this money. And the response from the department, at least in this instance, was KDH&E acknowledges this recommendation. And that's not the fault of the Office of, I feel like this is to show that they are pointing it out. It is incumbent upon the people responsible to recoup that. The problem is they don't have teeth to recoup that or enact anything to make the agencies be more effective and efficient with our dollars. So I very much know that there's hundreds of millions of dollars that the office has found and recommended be corrected, and it hasn't happened until we provide some leverage on agencies for doing so. Thank you, Madam Chair.
Seeing no other questions, thank you so much for being with us. Now, committee, we will move to our next conferee, which are representatives from the MCOs. And note that the written-only testimony was regarding our questions we had asked about the complex wheelchairs. Now we will hear from each of them individually. So we'll start with Sunflower and Alyssa Stinnett and Nanette Perrin. Microphone. There's a button right there on the front.
There's a button.
There we go.
I realized I should also have a slide presentation up. And I have a button for that too, but no slide presentation. Shall I proceed without? No worries. Happy to iron out the bugs for the other two. I appreciate the opportunity to present today and share how Sunflower Health Plan conducts our population health management and oversight with KanCare. Our presentation will focus on the core functions, our approach to fraud, waste, and abuse, and our partnerships and care program, all designed to improve outcomes for Kansans. I still don't have my deck, so I'm just going to proceed as though I do. At Sunflower Health Plan, our leadership and clinical teams bring together decades of experience in managed care, behavioral health, and long-term supports. Our mission is to deliver whole person care, ensuring that every member receives the right care at the right time and in the right setting. We work closely with providers, state agencies, and community partners to address the complex needs of our population. Let me begin by outlining the core functions of population management and managed care. Though we have always been focused on providing the most comprehensive care management possible, Sunflower has added several new programs and dozens of care managers, care coordinators, navigators, social workers, and support staff. This enables us to provide robust and localized services to our members under the KanCare 3.0 contract. And there I am. We take a whole person approach, integrating physical health, behavioral health, and social determinants. Our disease prevention and management programs are outcomes focused, aiming to reduce hospitalizations and improve quality of life.
I'm going to interrupt you just one
ma'am.
second. Committee, as everybody's frantically looking for this testimony, we'll pay attention to the screen because it's not downloaded, but it will be here shortly in our documents. It's under Sunflower staff. Okay. Thank you, Senator. On the third tab, third from the bottom, staff, Sunflower Health Plan. Thank you. Please proceed.
Of course. Provider engagement is important. We collaborate with physicians, hospitals, and community organizations to ensure seamless care navigation for our members. Our care navigation includes behavioral health integration, episodic and longitudinal care management, coordination of long-term supports and services, and managing transitions of care, such as hospital discharge planning. Second is utilization management. Sunflower's utilization management program, consistently compliant with the state-required turnaround time guidelines, and frequently evaluates operational practices to reduce provider administrative burden and to expedite determinations. Over the past year, Sunflower has implemented clinical human practices to improve the provider and member experience. Utilization management improves outcomes and resource optimization. We ensure services are medically necessary, evidence-based, and efficiently delivered. Cost containment is achieved by identifying and reducing unnecessary or duplicative services. We focus on patient outcomes, identifying members who need additional supports or referrals, or transition management. Utilization managers work directly with care managers to ensure members receive necessary services and supports when they need them. We focus on patient reviews. Reviews are conducted prior to, during, and after treatment, allowing us to promote quality care and contain wasteful spending. Treatment plan reviews at various stages help us to maintain standards and ensure that every dollar spent delivers value to our members and the state. See me with the clicker. A critical aspect of our utilization management oversight is the identification of fraud, waste, and abuse. Utilization management ensures that services provided are medically necessary and evidence-based, reducing overuse and inappropriate care. When we identify potential outliers or providers suspected of fraud, waste, and abuse, these cases are referred to our Special Investigations Unit, or SIU. The SIU conducts both retrospective and prepayment investigations. Retrospective investigations occur after claims are paid and may include site visits, provider and member interviews, and medical record reviews. Prepayment investigations are conducted before claims are paid and may include medical record reviews and tracking clean claim rates according to the state regulations. Our goal is to protect the integrity of the program, safeguard taxpayer dollars, and ensure members receive appropriate care. Our SIU uses a dual approach to identifying potential fraud, waste, and abuse, reactive and proactive leads. Reactive leads are those we respond to as they come in, such as tips from our hotline, our SIU intake email box, federal and state referrals, explanation of benefits, verification responses, and even media reports. Proactive leads are generally internally, using advanced data analytics and data mining to detect aberrant behavior early. We leverage social networking, referrals from internal employees in claims call centers, and utilization management, as well as predictive modeling outputs. Collaboration is key. We work closely with the state and federal agencies, include the Medicaid Fraud Control Unit, or MFUCU, KDHE, DCF, and other MCOs, as well as local and national working groups and task forces. This comprehensive approach allows us to identify and address issues quickly, protecting both members and the program. I'd like to highlight a program we have implemented to get ahead of potential fraud, waste, and abuse, and to better standardize operational and billing practices. Our Partnerships in Care, or PIC program, focuses on behavioral health monitoring and provider excellence. PIC has worked with 7 Kansas providers since implementation and has been well received as a practice improvement initiative. The PIC program is designed to analyze provider utilization patterns and cost trends in the Kansas market. We identify outlier providers, those whose service patterns are 2 to 3 standard deviations above the norm, in this case, and in areas that do not require prior authorization. The intent of PIC is not to direct care, but to build lasting partnerships with Kansas providers, ensuring that members receive quality, appropriate care. While PIC does not focus specifically on fraud, waste, and abuse or replace SIU, referrals to SIU or other actions may occur as file reviews are completed. To provide more detail on how PIC works, we conduct a deep analysis of provider performance, utilization patterns, and cost trends. Outlier providers are flagged for further review, and we engage them in collaborative discussions to understand their practice and identify opportunities for improvement. Our goal is to support providers in adopting best practice, improving documentation, and ensuring services meet state, national, and clinical policy standards. We want to help providers deliver the best possible care to our members and have been able to identify practice patterns that do not align with general standards of care or best practice. Through our PIC reviews, we have identified several common performance issues. Limited titration or transition plans, which can impact members' safety and outcomes and prolong services beyond what is necessary. Poor coordination of care, leading to fragmented services and missed opportunities for intervention. One-size-fits-all prescriptions or non-individualized care, which may not address the unique needs of the member. Service delivery that does not meet standard definitions, resulting in potential gaps in care. Missing progress notes, which hinder clinical ability to assess member progress and ensure accountability. Services delivered by non-credentialed staff, raising concerns about quality and compliance. Overlapping codes that violate state regulations, which can lead to billing errors and potential fraud, waste, and abuse. PIC was initially implemented in June of this year, and we're beginning to see some positive outcomes from the program. A few are increased adoption of best practices and standardization among providers. Implementation of PIC recommendations and action steps, leading to measurable improvements in care delivery. Improved clinical documentation, supported by the state, national, and clinical guidelines. The ability to evaluate and measure pre- and post-utilization patterns and trends, allowing us to track progress and to identify areas for further improvement. In closing, Sunflower Health Plan is committed to advancing population health management in Kansas, ensuring program integrity and building strong partnerships with providers. Our comprehensive approach to member and provider engagement assure we deliver high-quality, cost-effective care to members. Thank you for your attention. I welcome any questions.
Thank you so much, Representative Carpenter.
Thank you, Madam Chair. So you heard the Inspector General's report, the three main things, and then the MCO conflict of interest. So how are you addressing those? And this question will be for all the MCOs as they come up, but how are you addressing the three issues that he talks about in that, and then the conflict of interest?
Sure. In the conflict of interest specifically, if it were ever identified that we had a conflict of interest, it would be dealt with appropriately. I do not believe that we are among the conflict of interest identified. But what I heard in the Inspector General report was specific to utilization management. Was that your question?
That's fine. There are three main items here: delays to peer-to-peer, Medicaid beneficiaries being placed on observation status, and the consistency of how each MCO determines the level of care.
Yeah, absolutely. So we have, I'll address observation first because I'm very close to our hospital discharge planning and utilization management team. We are reviewing every single case on an individual basis using interqual criteria. So just as the hospital is using interqual criteria, we're evaluating members to assure that they are at the appropriate level of care. That means if they're in observation and they meet level of care for inpatient, we're going to encourage the hospital to change their status to inpatient. We're not holding patients at observation, but if they meet observation criteria of care, that would be appropriate for that member. Does that make sense?
Yes, thank you for that.
Representative Ruiz.
Hi, thank you for your presentation. What would be examples of that observation care that might be flagged and would really require a person to be transferred to basically a bed?
Sure. I'm a cardiac nurse by background, so I can give you a very specific cardiac example. When a person has chest pain and they come to the ER, their EKG, they're going to do an EKG and they're going to do 3 troponins, and that's the cardiac marker of whether or not you have any damage, right? They're going to do 1 blood test and an EKG in the ED, and then 2 more subsequent readings throughout the course of the next 24 hours. If the initial markers do not indicate that there's been any cardiovascular damage and the EKG is normal, we're going to admit that patient observation until we have indication that in fact there has been damage. So a change shows on the subsequent EKG, or the troponin rises, which occasionally the troponin does rise if we've had some damage and now we're seeing it over time. At which point we would transition the patient to inpatient and support whatever follow-up is needed, be it an angiogram or surgical interventions.
Thank you.
Quick question for you. We've heard conversations about the over-the-counter prescription drugs. It appears to me that if Medicaid is going to reimburse for those, that the member would pay the $3 cost and they would be reimbursed the $3. We're hearing that's not what is happening, that it's costing the state more, which means costing the MCO more. Could you tell us how that works with Sunflower?
I am not the expert to answer that question. I would need to defer to my pharmacy counterpart.
Okay, could you find that out for us?
Sure
and
will.
get back to us. Thank you so much. Yes, Representative Ballard, sorry, I didn't see your hand.
No, I just raised it. Thank you. What's ED? I'm sorry. You said ED.
Emergency department.
Okay, okay. Oh, that's what it was. Okay, thank you.
Also called ER. I know, I forget all the time. My dad says the same thing. What is ED?
Thank you so much. And next we will move on to United Healthcare and Todd Carlin. You do not look like a Todd.
No, good morning, Madam Chair. Jenny Esmert, I'm the CEO for United
Jenny.
Healthcare. Todd is joining virtually, so I know
Okay.
there's just been a little bit of technical issues, so I just want to make sure.
All right,
Okay, perfect.
great. Thank you so much. Thank you, Jenny. Todd,
Thanks,
are you
Jenny.
with us?
I am. Can you hear me all right? Are you able to hear me?
Now we can hear you. Go ahead.
Oh, good. Okay, great. Sorry for the snafu. I really would like to be there in person this morning. We had a little difficulty with my son getting on the school bus this morning, but I think this will work out. United's going to talk to you about, or I'm going to talk to you about, the fraud, waste, and abuse program specifically that United uses. You're going to hear a lot of the similar items that you just heard from Centene and probably with Blue Cross and Blue Shield as well. They're great partners, as well as our partners with Mafuku. Melissa, can you put the presentation online, or do you want me to do that? Hang on one sec. Okay, just a minute. I'm sorry, committee. We were going to coordinate this with an internal staff person, but I'll get that here in just a second. Sorry.
Todd, did you see
Yeah.
it? It's on the screen
Is it
now.
up? Okay, good,
Yep.
thanks.
Thank
Appreciate
you.
that. Oh, terrific. Let's go on to the next page. Melissa, if you could. Thanks. So the way it works, and I'm going to give you an example here on page 3 in just a minute, but there's a multi-step process in defining and identifying fraud, waste, and abuse. If you'd like further definition of the keywords, I'm happy to give that to you too. Particularly though, we start with detection. Similar to Centene, we have analytic detection. We're using approximately about 129, 130 different types of algorithms that are looking for schemes, code mismatches, things like that. When I started 7 years ago, we had 18 algorithms, and that's now over 100, 120. And that's important because the schemes keep changing, and we have to keep staying with the industry pulse of what types of programs are being created by fraudsters, if you will. The next piece, that once we've detected that there's potentially fraud, it moves to validation. And here's where we have investigators, the SIU teams, if you will. They're reviewing claims. They're conducting interviews with members or providers. And once they validate that there is a potential for fraud, it goes in two routes. One is prevention. The other is pre and post-pay investigations. Prevention is simply educating the providers on proper billing. Here's a really good example. About 5 years ago in the BH area, behavioral health, a trend started where there was what's called impossible billing, where providers were billing in excess of 24 hours of work in a day. Just a simple little idea. But we had to build algorithms to check and monitor for that, and then educate the providers. Providers get all sorts of education, not just from us. We issue about 600 to 1,200 letters individually to providers annually. But they also have their own boards, their own agencies that try to do education and teach them correctly. We do pre and post pay investigations. Those are more significant. They're going to be direct interviews with providers, facilitators, members on site. We'll ask for a record review, and which is quite extensive. If we've gotten to the point where we believe that we need to case report, we'll do that to both KDHE and Mufuku, great partners. There's a lot of communication between us and the state, not only during our monthly meetings, but always through emails, accepting referrals, cases, that sort of thing, pushing them back to us, and I'll get to that in just a minute. The correction is the collections. So next slide, please. It's an interesting case. I think the highlights of this primarily are it happened locally, and it's actually means that the program, the fraud, waste, and abuse program, is working as it should. In this case, what happened was an FMS provider made a tip to Mufuku. Mufuku then sent the referral or tip to us and asked UHC to investigate. And what we found was, in fact, that the member's spouse had changed the enrollment of the personal care attendant from a PCA who was supposed to be doing the work to themselves. And when they did that, they changed the bank depository information to that of the member and the spouse. So every month, the spouse would deliver timesheets and things like that to the FMS provider. FMS provider assumed that it was correct, and then went ahead and paid it. The total cost was about $40,000. But the best part about this was, and this is where the training comes in, the FMS providers are trained, our employees are, members are, providers are all trained to provide tips. In this case, the FMS provider did do the right thing. They identified that the personal care attendant had never provided any of the services. And once that was done, UHC went and collected the overpayment. I think the important thing to note here, and I think Steve talked about it earlier as well, these types of cases, or most cases, you can see started in 2023, April of 2023, and closed in 2025. These are normally long-term investigations, but we are able to go and collect the funds. Next slide, Melissa. These probably I'll move through kind of quickly. I want to get to the numbers page because that's kind of the validation that we're doing the right thing. A couple of Q1 and Q2 highlights. This is of 2025. We have identified approximately $1.6 million in cost avoidance from claim holds and additional record reviews. So when a provider becomes a suspect of a potential fraud, we'll ask for medical records. If they continue to submit claims in error, then we'll put up maybe a flag on them or a claim hold, which means that every time they submit a claim, then they have to submit records for review, which will either pass or not pass. So you can kind of see some of the impact of that, about 20,000 claim lines, 200 providers a month. We did talk about the algorithms and the provider letters. Next slide, please. Thank you. Post-pay analytics, did speak a little bit about that. We have submitted approximately 18 referrals to date in Q1 and Q2. We normally submit approximately 20 to 30 referrals in a year to the Mafuku unit. They will then tell us whether or not they would like to continue on with their investigation or have us go and investigate and determine whether or not fraud is apparent. Obviously, us, like I said, Centene and Blue Cross, we're all doing sanction checking, exclusion checking, working with your state boards, staying on top of that. We actually run, excuse me, about 230,000 providers through the sanction exclusion checking UHC monthly, staying on top of it. Okay, next slide, please. Yes, sorry about the small types. Tough type font. If you can read it, hopefully you might have a copy of it with you. Again, this is for the first 2 quarters of 2025. We identified about 3.2 million so far in 2025 that we've identified potentially fraud. We recovered about 3 million. Recovered is a term we use internally. You could also use avoidance, if you will, meaning the claim was never paid, but we do account for that as well. And then we have the prepay review, both medical and BH, at around 1 million. In terms of RX or pharmacy savings, approximately, we're going to probably be at about 500,000 or more to date, around 400,000. You can see last year at about this same time, we were running around 700,000 in RX savings. You know, if you look at this long term, like multi-years, you really want to see these numbers go down over time because you're hoping that education and change and provider behavior causes them to get on board, if you will. But there's always new schemes and new ideas and new ways to create fraud in the Medicaid arena. And that's kind of sad in a way, but we have to stay on top of it. Now, in terms of active investigations, these are not cumulative numbers. These are just strictly active cases that we're working on. Active cases in a quarter can be solved or they are still under investigation. These are good numbers overall, I think, for the program. Then, I don't believe we have any further slides, but I think the thing I'd like to comment on is fraud, waste, and abuse, program integrity, if you will. It was specifically called out by the CFRs, if you will, both in 438, which is what the rules that govern the MCOs in managing care, if you will, but also they dedicated a Code of Federal Regulations 455, which it goes in depth about program integrity and how to what the expectations are from the government for MCOs to monitor and manage to. I'll stop. You're going to hear kind of the same thing over and over again from the MCOs, but I'm sure you might have questions, and I'm happy to answer them. And that will be my presentation for now.
Thank you, Representative Carpenter. You had a question for each of these MCOs.
I did. I think maybe she'll be able to, it would be for her instead of.
Sure.
So, thank you.
Happy to start with the conflict of interest question, I believe was the first one. So
please identify yourself.
Oh, yes, I apologize. Jenny Ismert, I'm the CEO for United Healthcare Community Plan of Kansas. So on the conflict of interest, I believe you're referencing the allegations in the audit regarding, I think it was Change Healthcare. Okay. So just maybe quick layout of our organization. So our parent company, United Health Group, actually owns 2 individual companies, Optum and then United Healthcare. So I work for United Healthcare, our insurance benefits company, and then Optum actually is the separate company that owns Change Healthcare and some of the, the other companies that were referenced in the audit report. So Optum actually is a health services organization that provides those services not only to us as United Healthcare, but many of our competitors, providers, et cetera. And then there's very hard walls that stand up between our companies. So happy to answer any additional questions you might have around that.
Well, backing up to the three sides of conflict of interest.
Yep.
Have there been any corrections for delays to peer-to-peer review process? Medicaid beneficiaries are being placed in observation status when they should be classified as inpatient. And is there consistency to how MCO determines the level of care post-acute?
Yeah, of course. I'm actually going to invite Dr. Davis up here, my chief. He's our interim chief medical officer, to answer some of those questions.
Thank you.
Good morning, committee, Madam Chair. My name is Charles Davis. I am the medical director, LTSS medical director for United Healthcare Clinical Services. I'm sorry, United Healthcare LTSS. I'm the medical director and I'm interim chief medical officer at this time. And sir, could you repeat that question? I believe spoke to the OIG.
Yeah, the first one is, are there delays in the peer-to-peer review process under each MCO? It says yes, peer-to-peer reviews can take up to 7 days, depending on the MCO, resulting in delays of critical care.
So, yeah.
High rates of prior authorization denials result in additional peer-to-peer reviews, placed an administrative burden on hospitals and physicians, and causing further delays. One MCO reported over 50% of the prior authorization requests result in denial. So that's kind of my basis. I would think that you would have seen these three questions and at least sometime been prepared to address those.
Yeah, I think, for us, much like Centene, we review the individual cases based on clinical criteria. And I don't know if you want to say more about that.
Yeah, so again, we use Interqual, which is an evidence-based clinical decision support tool. It's used by healthcare providers, payers, and government agencies to review medical evidence and provide decision-making for the admissions and other services for our members. The peer-to-peers are the peer-to-peers for our members who are inpatients take, excuse me while I get my notes here, sorry. The peer-to-peer.
Madam Chair, in the interest of time, the committee, could you get that answers to me like in writing or something? I don't want to take up hours, and the chairman here is going to be killing me for taking up this time anyway. But if you could just get that to the committee at some point in time, and this goes for the other MCOs too, about what you're doing to address these Inspector General's concerns.
Yeah.
That would be great. So thank you. Sorry.
Okay, yeah, I'm sorry. I stumbled over that. Yeah.
That's okay. It's kind of one of those things. But I do think that it's important if we have an Inspector General to follow through with and run these to ground. So anyway, thank you.
Okay.
Representative Carpenter, I think those are all very good points, and it would be good for each of the MCOs to get back with us on that information. I do have a question regarding that we had asked for from Centene, from Sunflower, regarding the over-the-counter. Do you have an answer for us for that?
No, I'll need a follow-up with that too. I'm not the expert on that. I wrote that down, so we'll get a follow-up answer to
Very
that.
good.
Yep.
The last question that I have is probably for Todd, which is, I'm seeing a marked difference, which is, I think, a good thing, from 2024 to 2025 in your chart. Prepay review, cost avoidance, 5 million compared to 1 million. Can you expound upon that?
I sure can. When I was looking at this chart, You know, we have assists that help us prepare it. I think that the 2024 year-to-date, the term year-to-date is an error. That 2024 number is for the entire 12 months, not 2 months.
All right. That makes a difference. I
Yeah.
wondered and wanted to clarify.
Yeah.
Thank you
No,
so
I'm glad
much.
you asked. Yep.
Okay, Senator Petty with the last question, and then we'll move on.
So this is just a follow-up. You had said that the recovered fees, is that the term that you said are fees that were never paid out? Is that the general?
Yes, that is correct.
Okay, thank you.
Thank you so much. And now we'll move on to Healthy Blue and Brian Baer. Are you with us? And Lisa Dodd. Thank you.
Good morning, Madam Chair, members of the committee. Good to see you this morning. Brian Baer, the plan president for Healthy Blue, and I have with me Lisa Todd, who is our staff pharmacist at Healthy Blue. So we do have somebody here who can answer your pharmacy question. We do have a presentation. I don't know if we can load that. Yeah, okay. And I can just put it here when I'm done. Can you guys hear me, or is that, okay. How's that? Okay. While they're pulling up the presentation, and I think, are you guys doing that for us? Yeah, I'm doing it. Okay. The first slide is just an arrow slide that talks about, really we talk about fraud, waste, and abuse, and often those get used interchangeably and almost synonymously, but they really do have distinct legal definitions. And so just a reminder that there are differences between those, that fraud is an intentional criminal intent to mislead, whereas fraud and waste occur commonly and can be unintentional or semi-intentional, and there are different examples of each of those. The lion's share of the dollars are in abuse and waste. So I know we like to talk about fraud because usually some pretty alarming examples. But generally, most of those dollars that we try and recoup for the program are actually in fraud and waste. And so examples of waste would be things like ordering a service, maybe a procedure or a drug that's not necessary. You could have a therapeutic equivalent or a procedure that's less costly to try first, but instead you go ahead and go to the higher intensity. Abuse would be upcoding or charging something maybe that for a higher value of evaluation and management when really you just did a 15-minute meeting. And then fraud, I think we all know what fraud is, when you're intentionally saying, hey, I provided this service when you didn't and expecting payment. So those are really those three buckets we think about when we deal with fraud, waste, and abuse. And then the MCO has various tools to deal with those, which the other MCOs have talked about, everything from data mining to prior auth to postpone and investigate. And so really when we talk about, oh, here's the first slide and the second slide. We're on number 2 now. Oh, I've got control. Okay. So here's our continuum between waste, abuse, and fraud. And then the tools we use from data mining, prior auth, and then if we do come across fraud, the criminal referral. And so what I thought we would do today is run through the examples from a pharmacy lens. So I've got Lisa Todd here, who is a pharmacist, graduate from the University of Kansas Pharmacy School. She's a 4th-generation Kansan and has been in pharmacy, I think, for 30 years. 28. And involved with Medicaid program for 20?
Almost 19.
Almost 19. I'm rounding up. So, Lisa, if you'd introduce yourself.
Yes, hi, Madam Chair and committee. Thank you for, can you hear me okay? Sorry about that. Yeah, so Brian introduced myself. Yeah, I'm a lifelong Kansan and have worked for Kansas Medicaid for many years and just really appreciate that opportunity to serve our members. So as our slides talk about, that we have programs in place that ensure that drug utilization is done appropriately, and we also focus on the member safety. We have 3 programs. We have prospective, retrospective, and lock-in. See if I can do that. So the prospective review is a program where we actually communicate with the pharmacist as they are filling that prescription. We can send, it is focused on safety, but it also does it will highlight different areas of fraud, waste, or abuse. An example is a couple weeks ago, we had a pharmacy in Emporia that was submitting a claim for an antipsychotic medication. Our program caught that as an alert, sent the alert to the pharmacist while they were filling the prescription of some potential drug-drug interactions. The reason why is the member had actually received 2 different mental health medications and a seizure medication the week before at a different pharmacy prescribed by a different provider. So the pharmacist took action on that right away and called the doctor. The reason why this is really a concern, it is appropriate at times to take, several mental health medications and those type of medications together, but we want to make sure that since we have different players, different providers, so some of the serious side effects could be hallucinations, also high heart rate, and then also it could increase their seizures. So the pharmacist did get a hold of the provider and was able to talk to them about which medications should be discontinued or which ones should be filled. So as I stated, it is focused on safety, but also it did decrease waste in the system. And the next slide, we're going to be talking about retrospective review. So this is where we use data mining and analytics, and we look at pharmacy claims to see for any outliers that might be fraud, waste, and abuse. An example of this, actually, back in July, we had a pharmacy in Pratt that they had a member that, one of our asthmatic members, we had noticed in our data that that member was just using their rescue inhaler, and that's not recommended for the best outcomes. You want to use a controller or a maintenance inhaler to help reduce, the asthma, and use the rescue inhaler just for rescue. So we sent that tip to the pharmacist. The pharmacist called the provider, was able to get a prescription for the maintenance inhaler, was able to fill that and counsel the patient on the use and the importance of that. So that's another area of member safety. And then also this improved the member's asthma condition, but then also reducing the usage of the rescue inhaler, and then potentially decreasing the likelihood of an emergency room visit. And the last program that I wanted to talk about is focused on abuse. This is our lock-in program, and we use data mining again. We look for several different scenarios, but a couple of them that we do look at is we look at members that are potentially using, we usually pull at least 5 or more controlled substances, 3 of which could be opioids. And if they've been filling those at 2 or more pharmacies and prescribed by 2 or more providers. Another thing is we look at like misuse of the emergency room. So we will look if a member's been going to the emergency room for non-emergent visits, 2 in the last 30 days, then we will look at that. So we do have a lock-in committee, clinical staff that we review all of the data and review those members on an individual basis. And if we do feel that there may be abuse at play, then we will lock that member into one prescriber, one pharmacy, and one hospital. So that would limit that member to only be serviced by those providers. So that way we can help with the member safety and then also decrease abuse. In conclusion, I just wanted to say that, Healthy Blue really understands the importance of fighting fraud, waste, and abuse while also ensuring member safety. Thank you for the opportunity to visit with you guys. And if you have any questions, I'd be happy to address those or answer those.
Lisa, you heard the question that was asked earlier about over-the-counter?
Yes.
You know how that's handled?
Can you re-ask that question? What the
Sure,
over-the-counter is?
gladly. So a physician, a provider prescribes an over-the-counter medication. It can often be $3, $4. How's that reimbursed? And who's benefiting from this higher reimbursement?
Okay, so we don't pay for any OTC. There's specific list of OTCs that are on the Kansas formulary. They're very minimal as far as there's, like Tylenol and ibuprofen, those type of things. There are quite a few OTCs that when they first came out on the market were prescription, but now they have gone over the counter and they're actually cheaper to dispense those than using a prescription strength of maybe in that same drug class that hasn't moved over to the over-the-counter. So back to the reimbursement. So we do have, so that we would pay for the dispensing fee, but the members don't have a copay, and we find that if it might be more beneficial for a member to receive a lower cost drug than, say, if you were able to cover Tylenol, then they may be able to use that as opposed to, an opioid. So, yeah.
So you just said we don't reimburse.
Oh, I'm sorry, we do, I misspoke. I'm sorry, we do reimburse the over-the-counter, and we do reimburse a dispensing fee on that over-the-counter.
So if I were the member, a Medicaid member, I go in and I buy the over-the-counter ibuprofen that the doctor prescribed for me, and it's $4, and you said there's not a copay, correct?
There's no copay for the member.
Okay, so that needs to be done at the pharmacy, or how is there
Yes.
no copay?
Yes, so the provider has to write a prescription for it. It has to be treated as a prescription. Otherwise, there's no way for us to reimburse those as a pharmacy claim.
So they pick it up in that area of the
No.
pharmacist? No.
No, so let me clear that up. So I apologize, I wasn't very clear about that.
No, it's okay.
So the provider will send in the prescription, whether it electronically or handwrite the prescription for the ibuprofen, then take it to the pharmacy. The pharmacist fills it and processes it. We check to make sure it's that specific drugs on the Kansas formulary, the Medicaid formulary. If so, then we will adjudicate the claim. The member doesn't have a copay. Members don't have copays for any drugs in Medicaid, unless they're in spin down. That's a whole nother story. And then the pharmacy is reimbursed for the medication, and then also a dispensing fee.
So it would appear that it would be less expensive for everybody all the way around, Because those dispensing fees can be $15, right?
Oh, no.
No.
The highest a dispensing fee could be is $10.40 in Kansas.
Okay, so let's say that the drug itself is $3,
Mhm.
but the dispensing fee is 10.
Mhm.
Is there a higher charge than what it would have been retail within the, wherever
No,
they play it? No.
no.
So it'd be the
And our
10.
pricing structure can depend on what what rate that specific drug is set at. So
whatever rate the formulary states that the drug is costing, that's how much is reimbursed to that pharmacist.
Yes.
Correct?
Mhm.
Plus the $10 dispensing fee.
Correct.
Thank you for clarifying that. Committee, other questions real quickly? All right, seeing none, thank you so much, Lisa, and thank you, Brian. Committee, we're going to move on to our Kansas Department of Health and Environment and Secretary Stanek. Thank you for being with us.
Thank you. Are you going to put up my presentation? Oh, yeah, you are him. Sorry. All right. Good to see you all. Janet Stanek, Secretary of KDHE. I'm just going to kick off the presentation today on pages 3 and 4 per some requests that were made related to measles. First of all, one moment. Okay, you see the slide? We did announce the end of the measles outbreak in southwest Kansas on August 21st. We based that on 42 days passing without any additional cases being identified. 87 cases were associated with the outbreak, affecting 10 counties. Most cases were in children 0 to 10 years old, and most cases were not vaccinated against measles. There is some additional data by age group, by vaccination status, and by county. I will do my best to answer any questions on that, but I did not know what further questions you might have. The information on the costs was in the follow-up document that you got from the July 14th, 15th meeting. Oh, I apologize. Yeah, that's all I hit on measles, just one slide. Is there any questions? If not, I'll move on. Huh? Oh, did I go the wrong way? Oh, okay. Oh, there. Okay, thank you. All right, so slide 4 is on, I hope you know by now what the Rural Health Transformation Program is. I was asked to present on this, so I'll give you a little overview. We're on a tight timeline with this, part of HR 1, and Governor Kelly did announce that we will work to apply for the $50 billion program to acquire funds for the rural healthcare system. This is for the system in total. I want to emphasize that it is not for hospitals, as was originally announced by the federal government. KDHE is noted as the lead agency. We had to do that per the requirements, and we've created an interagency team between KDHE and KDADS, so Secretary Howard and relevant personnel from our agencies are involved. We have engaged with KU's CARE Collaborative to support the development of the application and stakeholder process. This is very big on making sure that we have stakeholders identified and are engaging them, which we are. We did, through the governor, create the Kansas Rural Health Innovation Alliance. We're calling it KRHIA. And we have already convened one stakeholder meeting, which occurred last Thursday, hosted by Kansas Health Institute. It was a WebEx, and all of the agencies that were appointed to the alliance were allowed to bring 4 members from their respective organizations to weigh in and do breakout groups and so forth, and talk about also the long-term governance and management of funds, should we be selected, which we are very hopeful that we will be. The timeline is very aggressive by the federal government. There is a ton of work going on with this. I want to thank everybody, including our stakeholder groups, that's helping with this. The app was released on the 15th of September. It needs to be fully submitted by midnight November 5th, which is right around the corner. We did submit what we had to do requirement. It was an optional, but then was emphasized a requirement, a letter of intent, which we did, and we received receipt from CMS on September 24th. Again, we talk about the meetings that are being held. We have a SharePoint and a Dropbox where we're collecting information from various interested parties that have ideas about how we could use the money. We want to be strategic about it. It would be related to transformational processes, not one-offs related to, for example, if a hospital needed to buy a new piece of equipment, that is not allowed. This is about showing that you're transforming healthcare, and there's a bunch of different categories. It's very detailed. So half of the $1 billion, that $50 billion, would be awarded to all approved applicants. So if you're approved, there might be all 50 states, there might be 20 states, that would be split. And the remaining is based on your plan. So that's more discretionary, and that will be decided upon by the CMS Administrator, Dr. Oz. So I would just say that we will keep you all posted, but this is a core focus for Kansas right now. Any questions for me?
A question from Representative Carpenter.
Okay.
Thank you, Madam Chair. So, two things. One, are there any plans to have a legislators on the Rural Health Innovation Alliance? I noticed that it was all providers.
That was decided, the governor appointed, but there is, yes, to engage, absolutely.
I think that would be very prudent.
Yes.
Since we end up paying the bills. So the other thing is on the remaining half, is there any truth to the fact that states that did not expand or have not expanded Medicaid will get a larger portion?
Have not heard that at all. No, I don't believe that's true.
Okay, very good. Thank you.
All right.
I too have a quick question about that, and that is, yes, you're right, it's a very aggressive timeline. Who put on the restrictions? Was that in the state that's putting on the restrictions that it must be transformative, or is this something that the federal government has put these restrictions on?
It's the federal government. They're very clear, have given very specific examples. We're happy to share for you the notice of funding opportunity. They give examples of what's able to be applied for versus, again, these one-offs. It's not about individuals. It's about right-sizing healthcare. It's about what are you going to do different related to perhaps adopting policies and statutes you haven't been done yet. We're identifying all of those things. There is a very aggressive and comprehensive point system also. Therefore, that's why we have help from the collaborative trying to piece this together and get us a solid application. I feel really good about our process. A lot of this was about process, but yes, the restrictions are by the feds.
And you feel like we can have something ready to submit before November 5th?
Yes, I do.
Very good. Please continue.
Okay, go ahead. I think I don't have any more on that, just, I think Senator Petty might have a question.
Quick question from Senator Petty.
So Secretary, so you're on a timeline to get in by November the 5th, and then by December the 31st, you should know whether you for sure are part of getting the split, the $25 billion, because you'd be if you were approved, or would you know prior to that whether you've been approved?
You'd know if you're getting all of it because you submit once, and they decide if you get the second half when we get notified in December 31st.
Okay, so you'll know both for
Yes.
both parts. Thank you.
Thank you. Please go ahead.
Chair, are we going to be able to ask more questions after the secretary's done, or?
Yes, we're running a little bit behind, so I'm going to have her go ahead and finish, and depending on how much time we have after that, we will. Thank you, Representative Reese.
That is all I had. I'm going to turn it over to Christine Osterland, our Deputy Secretary from.
Was your particular question for the Secretary? Please go ahead, Representative Reese.
Yes, it's regarding this grant, the Rural Health. I want to put in a plug for a possible expansion to the navigators that are very present in many of the rural areas now in the clinics. That is a transformational type of a program that they could use the funding so they could expand.
I would say this, and then I'll let Christine get up. Things like that have been formally submitted. We had a form and an application process for people to give us ideas. And what we're doing is taking themes, and themes like that are emerging. So yes, correct. Thank you. And we'll note that anyways as a sidebar, okay? Thank you.
Christine, thank you for being with us, Deputy Secretary. Please go ahead.
Good morning. Christine Osterlin, Deputy Secretary of Agency Integration and the State Medicaid Director. And it was the same presentation. And I'm going to see if I can walk and chew gum at the same time. Madam Chair, do we want me, since I have several topics, do we want to do where I'll do a topic and then pause for questions on that topic, or do you want me to go all through the presentation?
You know what? If you don't mind pausing, that would be great.
Okay.
Thank you.
Oh, that's KDAD's. It was the same presentation as Secretary Stanek. So while we're waiting for that to come up, my first topic will be on some of the activities up at the federal level, both with, thank you, with HR 1 that passed in July, as well as just some other guidance that we've received from CMS over the last few months. So I'll kind of hit high level here, and then we've got some specific dollar amounts and numbers on some of these items in the next few slides. So some of the highlights of HR 1 that impacted Kansas, I will say that there were several provisions in that legislation that were specific to expansion states, so they do not apply to Kansas. So the main ones that impact Kansas, there were changes to immigrant eligibility. So these are folks legally in our country, but HR 1 moved some of those statuses to not being immediately eligible for Medicaid. So currently, if you legally immigrate into the United States, there are certain categories where you're eligible for Medicaid the day you enter the country if you meet all the other criteria. And so those have been restricted. State-directed payments, I think we talked about this a little bit in the last presentation. For non-expansion states, our state-directed payments have to go from average commercial rate down to 110% of Medicare. I'll talk at a very high level what that might look like for Kansas. Another change is what's referred to as prior medical. So when an individual applies for Medicaid, there's some opportunity if they have very large expenses to be paid. Currently, it can go back 90 days where we could pay like a hospital bill or a nursing home for going back 90 days. For non-expansion states, that is going to be reduced to 60 days. But one thing they did expand in the prior medical is currently, if you are enrolling in CHIP, you do not qualify for prior medical. CHIP will now be included and eligible for prior medical coverage. Another provision was a delaying of the eligibility final rule and the nursing home staffing final rule. So for Kansas, there were two pieces of the eligibility rule that we had not yet implemented. One was related to Medicare savings programs, and another one was limiting eligibility redeterminations for adults and people with disabilities. So those now have been delayed until 2035. Another provision is prohibiting federal payments. There's specific criteria in the bill around a provider that would not be eligible for Medicaid payments. You see there they have to have $800,000 or more in Medicaid payments in 2023 and perform abortions. We have looked at our claims data. We do not believe that we have any provider in Kansas that meets those criteria. On the good news, there's an HCBS expansion provision. No guidance yet out on this, but the concept is, from what we can tell from the legislation, is to allow states to have HCBS waivers prior to someone meeting nursing home level of care, which the intent being that obviously you can delay them meeting that level of care, which is much more expensive. And then there's a provision, they call it waiving of erroneous payments. What this does is this restricts. So currently when we have a PERM audit, we have those every 3 years. It's a payment error rate measurement audit. There's going to be restrictions on basically getting a waiver of, if you will, of the amount of federal dollars that you owe back if you have errors. So it's going to limit those opportunities to kind of get those paybacks waived. Then there is enrollment in multiple states. So by October 1st of 2029, CMS must have operational a verification system. This would be nationwide that states could use to check for multiple state enrollment, because obviously I think you're all aware you can only be enrolled in one Medicaid state. This would also have a provision that it would also look at the marketplace. That has to be up by 2029. In January 1 of 2027, they are going to allow some instances where MCOs can submit address changes to the state, and we can accept those as what they refer to as verified. In the interim, CMS has indicated that they're going to start sending files to states that would indicate if you've got enrollees that have multiple state enrollment. That file has not been received yet, but we do believe that will be in the very near future. And then there's a couple provisions around enrollees that are deceased that are enrolled in Medicaid, as well as providers. On the provider, best we can read that language, we believe that we're in compliance with that because we do those checks against the death master file today. On the disenrolling deceased individuals, we believe we're in compliance, but there is some indication in the language that there might be a new database at the federal level, so there might be a new interface. So we'll see about that and what that entails. So that's kind of the highlights from HR 1. The next couple items I'm going to go over are communication from CMS to the states. One is we received a letter. All states received a letter that if you do 1115 waivers and you're offering continuous eligibility to any population not mandated in federal law or regulation, that CMS will not renew those waivers. So for us, that's our caretaker medical, the continuous eligibility for caretaker medical, which are really your parents and legal guardians who are not disabled or not pregnant. We don't have a date yet. The waiver end date is December 31st of 2028, so we don't know yet from CMS if we'll be allowed to go the whole entire time, and when that waiver hits its renewal point, that's when it would end, or if they would provide an earlier date. And then we were, all states were notified in August of 2025. We started receiving from CMS.
Madam Deputy Secretary, if I could for just a moment, if we could go back to CMS notified they did not anticipate approving new state proposals or extending existing approvals. Are you saying that we have continuously been eligible caretaker adults that they have been eligible for Medicaid regardless of their income?
It was a 12-month, so we have currently in Kansas, we have 12 months continuous eligibility for someone in the caretaker medical population. So once they're approved eligible, so they go through the application process, then they're guaranteed 12 months of eligibility until their annual renewal point, which then again, they would have to verify they meet the eligibility standards.
So then you're saying we give them 12 months and that gives them time to see if they meet the eligibility, but they're automatically put onto the program?
No, they have to go through the application process. It's not a presumptive eligibility. They have to, at the time of application, provide their pay stubs. They go through all the requirements of eligibility. So it's not a presumptive, but once we approve them that on the time that they applied, they meet the standards, then they keep their coverage for 12 months.
And so are you saying that there is something that would be changed about that?
We wouldn't be able to provide the 12 months of continuous coverage.
Okay, thank you. Yep. Please go ahead.
Oh, and then this last one, and I've got some statistics in there. So we received our first immigration data file. So this is, again, these are individuals who are in the United States legally who are receiving Medicaid in Kansas. Our first file, we received 442 members. You can kind of see the statistics there. We had to look at all 442 to verify that they were indeed in a immigration status that would allow them to be eligible for Medicaid. 73 folks, when we got the file, were already discontinued. 128 were verified as U.S. citizens. So really what that probably meant is the time they initially applied, they were in an immigration status and they have now become a U.S. citizen. And then 241 were researched. What we do is we go back out. There's a federal system that we go through an interface. It's called SAVE, but it's the Federal Citizenship Database, and that's where we verify these. 195 were determined to be an eligible non-citizen. 14 have now just recently become citizens. We did have one individual who at the time of application was in a parolee status that was eligible for Medicaid. When we looked at this file, that status had been removed and saved, so they no longer are eligible. And then we have some consumers that we are still waiting on documentation. I will say this system that we use does not give real-time results, and so it can take up to 30 days to get documentation. Sometimes it comes as quickly as a day or two, so it's a little bit kind of all over the place. So, and we will receive, our understanding is we will receive this file, a file monthly from CMS to review our immigration statuses. This is going back now to HR1. This is to give you some kind of dollar amounts. So in our reading of the language, we estimate that at least 2,234 current Medicaid members will lose eligibility due to the changes in who qualifies as an immigrant for Medicaid eligibility. Provided some annual numbers there. It's basically right now we pay about $3.6 million in state general funds to cover those individuals and just shy of $6 million in federal funds. So when this rule goes into effect, October of 2026, again, we know that at least 2,200. I will put a caveat there because the language is broad. When CMS guidance is issued, that number could go up. We anticipate it will. I really can't tell you how much. It'll just depend on how they interpret and what their guidance says. Prior medical, this is looking on the actual Medicaid side of it. This is reducing prior medical from 90 days to 60 days. Again, these payments are primarily made to hospitals and nursing homes. You can see that because it goes into effect halfway through our state fiscal year 27, you can see that we in all funds anticipate a savings to the state of just over $5 million. In state fiscal year 2028, when it's a full year, about $10.3 million is what we will save in prior medical expenditures. On the flip side, this one I will say has a, you can see we do a minimum and maximum. We've never done prior medical and CHIP before. That's never been allowed. So really it's very hard to estimate how many people may take advantage of it. Our CHIP children are typically healthier children. So you're going to see quite a spread in the numbers of what we anticipate, but this will be a cost to the state. Again, if we look at a full fiscal year, you can see it would range from really 366,000 of state general funds all the way up to 5.4 million, just depending how many individuals. We think it will be on the lower side, but we really don't know.
Quick question for you. This is not something the federal government is telling us we must cover. This is something
we must cover. No, this is a HR1 and this is a must.
Must cover 60 days of that.
Yeah.
All right, thank you.
And it's a must also on the Medicaid side of reducing it from 90 to 60.
And for states that expanded Medicaid, it's 30 days, correct?
Yes, correct, yes.
Thank you.
This is just a little bit of kind of what the impacts will be. I think our biggest concern here is, for nursing homes or other providers, would they be as willing to see someone who is currently not enrolled in Medicaid if that time frame was limited? So again, there could be some higher medical costs for our families. We could have some providers who are a little bit more cautious. So, again, something we definitely will be watching as we roll this out. And with that, that's kind of a summary, a very quick summary of everything going on at the federal level. I can stand for questions.
Senator Erickson, you had a question?
Yes, thank you, Madam Chair. Thank you, Christine. Just a quick question going back on slide 9. The last bullet point talking about 241 consumers required additional research. to confirm they met an eligible non-citizen status. This was due to questionable or discrepant information in the case file. So is the default when there's questionable or discrepant information to approve them to be on?
If we, and this would be true even broader than just immigration, really, in anything in we have a verification plan that we have to submit to CMS and be approved of how we verify our individuals on Medicaid. So if there's discrepant information, we must send a notice to the member to have them be able to submit documentation to try to clear up the discrepancy. Sometimes it can happen. You could have someone, for instance, on our side, or it could be even at the federal government side, they might transpose a birth year. And so it looks like, the information doesn't match. But in those cases, then we would, if we see discrepant information, then we would give the family an opportunity to submit additional documentation.
So these 241 were not on Medicaid?
They were.
They were, but they had questionable or discrepant information in the case file. So how did they get put on with questionable or discrepant information in their case?
Well, what this is meaning, and this probably isn't worded real well, is CMS, when they sent us the file, felt like maybe there was discrepant information. When we checked them, if you go down below, we were able to confirm, like, for instance, so that 241, 195 of them have since moved to be a U.S. citizen. So it is going to look like, if you look at immigration status, that there's discrepant information because they're not going to have an immigration status anymore because now they're a U.S. citizen. So it required us to go in and validate why CMS was thinking, well, this is not an immigrant. They don't appear to have an immigration status that qualifies for Medicaid. We could go out and see that they are now a U.S. citizen, so they transition. So you're right, Senator, that's a good point. That wasn't worded real well. We'll try to kind of clear that up, but that's what we were doing is researching to say, why does CMS think potentially this person didn't meet a correct status?
There are 31 still under review that are currently on Medicaid.
Yes.
Am I understanding that right?
Yes, yes. Yep.
Thank you, Madam Chair.
Senator Petty.
Thank you. Actually, my question is on the same page. So you said that will you then be getting the same thing every month?
Yes.
So every month you will be getting the same kind of file on the current people that are on Medicare or Medicaid.
Yeah, on Medicaid that are in a non-citizen status.
That are in a soon to be in a non-citizen status. And then you're going to then have to every month verify whether, as in this case, like it started out with the 241, it's now down to 31. Is that correct?
Yeah, we have to verify every individual on the file.
And that would be coming every month that you have to do that.
Yes.
So is that, so what kind of staff time is that then taking?
We'll be evaluating that as we go forward. Off of one file, it's really hard to say because we don't know every month, is the file going to stay the same? Is it going to be bigger? Is it going to be smaller? You might assume it might be smaller, but we will be doing that evaluation because it is, while the interface, when we kick that off, that's automatic, but when the result comes back, staff do have to manually enter those results into keys. That is not automatic.
Thank you.
Representative Carpenter.
Thank you, Madam Chair. So I guess maybe my memory might be failing me, but I thought we asked a question at the previous KanCare meeting about illegal immigrants receiving Medicaid. And I thought the answer was no, there was not, but it was paid for out of a separate bucket that was all federal funds. Did I just imagine that, or what's going on here? Because I see now that this is costing $3 million worth of SGF.
So this is for folks legally in the country. All these numbers are people that are here legally.
Presumed. I mean, obviously, your sheet earlier than that, some of those folks aren't or were not. But so you're saying that there is no state money going to illegal immigrants on Medicaid?
No.
Okay. I just want to make that clear.
There are some states that do provide coverage to those, but Kansas does not.
Okay, very good. Thank you.
Now, what can happen, and I will just clarify, like with this one individual in this results, at the time that they applied for Medicaid, they had a parolee status, which made them eligible for Medicaid. When we got the file and we went in and rechecked them, that status had been removed. So there still can be changes to their statuses once they apply. So it's not always just a constant. I won't say that that's common, but it does happen.
Very good. Thank you, Christy.
Additional questions, Committee Representative Ruiz.
Thank you, Madam Chair. On slide 10, the immigrant eligibility piece of it, you have that at least 2,235 members will lose eligibility, and members meaning these individuals are here legally, they're qualified immigrants. Do we have any idea out of those 2,235 whether they are employed, if they're employed like in our rural areas with farmers, dairy farmers, any of those kinds of industries? Do we know if they are employed in that and they will be losing eligibility?
We could run that data to see how many of them, either at their application or their last renewal, if they had an employment record. Yes, we could pull that data.
Yeah, because I like to know what additional impact it will be to our economy.
Yep.
Thank you.
Yeah, we can pull that.
I think what we have seen on a national level is that under the prior administration, there were lots of people that were allowed into the country that are now given legal status that are not eligible for legal status currently. And that is probably part of this issue, is that they were allowed on because they were considered legal, but they're actually not. Did you have anything more for us?
Not on that topic.
Okay, please go ahead.
Okay, let's see. Now we're going to move into some follow-up to an audit that the Inspector General did on out-of-state residents. Okay. There we go. This first slide is just a little bit of background on kind of the umbrella under which we have to operate on the Medicaid side. There's, as always with Medicaid, a lot of federal guidance around timelines and what we can do and when we can do it. The quickest way is if it is reported to us directly, obviously by the family, we can act. We still have to allow timely notice, but we can act immediately. What I find interesting on this page, and I wanted to point out, and I know the Inspector General has talked about this a few times, that the Paris report, which today is kind of the primary source of information that we receive from the federal government on trying to determine out-of-state residents, we must allow 30 days for the member to respond if we get a hit on the Paris report that they might have an out-of-state residence. Compare that to if we get a lead from another source, we only have to give them 12 days. So it kind of talks to the unreliability of Paris. I will put it in those terms, that they get a longer period of time. I'll go on to the next slide. So that's just a little bit of what we go through. There are reasons that someone can live out of state and maintain their Medicaid eligibility. Obviously, they can be residing in an out-of-state institution. They are minors or individuals who are not legally competent. And then temporary absence. And that's a very broad term. That's the one I wanted to focus on. Most common example would be they leave the state to go to college, but they could leave the state to go take care of a family member. As long as they tell us that they intend to return to Kansas under the Medicaid rules, they would be able to do that. And there's not currently, at the federal level, there's not a timeline to that. You know, there isn't well, you can do that for 6 months. You can do that for 90 days. It's a very open-ended, broad aspect. So what have we been doing since the audit came out? So we, as you can tell, the Paris report, lots of concerns with reliability, a lot of just data issues with that report. So we partnered with Public Consulting Group. They did a free pilot for us to kind of look at our resident members, to kind of look for potential out-of-state residency. We sent them, as you can see, just over 10,000 records. 3% came back, 315 as potentially having Medicaid in another state. Of those, 58 were no longer active on Medicaid. And then you can just see the breakdown here. As we would expect, most of them are in the family medical category. Of the ones remaining, those are our most mobile members as far as changing addresses. So the next step when we get those back is we always try to look for, and this kind of comes back to the recoupment issue. One of the things that we always try to look at is, do they have claims in Kansas? The reason that that's important is that if a provider provided a service to a member, because at the time that they provided it, we said they were eligible, they really should be paid for that claim. And the same with the MCO. If they were providing services to a member because we told them they were eligible, if we recoup the money, I'm not even sure from a contract perspective that that would be legal because they complied with the terms of their contract. But currently, we don't have an automated process to check for paid claims. And so it's a very manual, labor-intensive process of people going through hundreds of records in a manual way. So we've been working with Gainwell on options to create an automated process where we could give them a list. They could do a bump for us. If there is no claims, we could move to recoupment. If there are claims, we would still end their eligibility if appropriate. But obviously, recoupment becomes a different issue. Gainwell has come back to us with a broader solution than we actually asked for, which is, I think, is encouraging news. We're going to be doing a pilot with them. But the solution that they're coming up with is Gainwell currently, either through their third-party liability solution or their claims payment solution, they really represent about 95% of the Medicaid beneficiaries nationwide. They're going to make an option available to states where we could use their data to check. So if someone's applying for Kansas Medicaid, we could do a check to see if they have eligibility in another state, or at renewal, or whatever time frame might be appropriate. On the claims side, we could do a bump to see if they had claims payment in other states. So we were on a call with Missouri, Oklahoma, and Kansas, and I think all three states are going to join up to try a pilot to see if this kind of has the results that we think it may. So anyway, more to come on that, but I wanted to let you know that we are continuing to work on improving our out-of-state residents. And then I will just point out, when H.R. 1 fully takes effect in 2029, there'll have to be guidance issued from CMS, because if they do have Medicaid in both states and they have claims in both states, which state, we would need information on which state is to close and which one is to remain open. But more to come on that. But I'll continue to report on out-of-state residency and our efforts to get this off the ground and automated, and something that we can be doing on a monthly basis. This is just a little bit more detail around the I'm sorry, I'm just going ahead. I will pause there because I am done with out-of-state residents.
Senator Petty.
Thank you. So just so I understand this, when you mentioned the Paris system, does that help you verify if they are being counted in another state?
Yes, it is supposed to be, yes, an indication that they could be living out of state. The problem with the Paris report is states are only required to actually submit information once a year. So if it is a state that's just doing once a year, the person could have moved 3 or 4 times. We get it every quarter. So it just has a lot of issues. There's no data validation. Every once in a while, you'll see a state that they uploaded a file. Everybody has the same eligibility start and end date. Probably not, which is why then you get into the whole 30-day timeline. And, you know, I know the Inspector General has even talked about it. It's not a great data source. It's what we have, but we're continuing to try to find other data sources that would be more timely and more accurate.
So now with HR1, you're going to have to check residency every 30 days?
What they'll do, this, again, no guidance has come out. How I believe it will work, it will be a hub, and that you will, and again, I don't know what CMS guidance will be of how often. What we're hoping as the states, that we would actually get a ping if one of our members appeared in another state's as Medicaid enrolled. And that other state would hopefully get the ping before they even enroll them. So we're hoping it's going to be an interactive, but if it's not, then yes, we would have to submit at whatever routine that, you know, CMS, you know, dictated, which could be monthly or at least at application and renewal. But we're hoping it's interactive.
Thank you.
Representative Bueller.
Thank you, Madam Chair. Thank you, Christine. When I saw the word Gainwell in here, it kind of triggered me back to Social Service Budget Committee, and curious, is there any, is the existing software that you have with Gainwell sufficient to do the pilot, or will we potentially be seeing budget impact to be in compliance with HR1? I'm just, if you can predict the future.
Well, HR1 will be, that's a hub that CMS is going to bear the cost for. So I don't believe there'll be a cost for the states for the 2029 solution. The pilot we're going to do with Gainwell, we haven't got into cost yet. I'm kind of the opinion, again, obviously this would be negotiation points, that, you know, if they are convinced that this solution can help us, then shouldn't we pay them only when we're successful? Okay. And there are those kind of payment arrangements. Again, we haven't got into cost because we really wanted to try the pilot to see if we got the results that we think we're going to get. And it may even be possible, under our contract with Gainwell, we do have some programming hours available. So I can't say yet if it would need to come to the legislature. And then there's also the thing of just even cost savings to the program, because obviously if we're ending eligibility much sooner than we would, there's a savings to the state at that point, you know, as well. So I think a lot more to come yet around the cost side of it.
Okay, thank you. Thank you, Madam Chair.
As Secretary, Representative Ballard.
Thank you. May I?
Is that a promotion or a demotion?
I will make no comment. May I back up just a little bit because of something you said about immigrants, and then you said out of state. So is that okay? All right. What is the status when we start talking about immigrants in this country, the H-1Bs? All right, so those that are on green cards. Okay, so those people are here officially on visas. And then maybe when their visa is ending, we're looking at their particular expertise and we want to utilize them. So therefore we hire them in this country. So there is an employer involved here and they're on their green card. But it takes anywhere between 8 to 10 years or longer to become a citizen of the United States, and you have to be 21 years old. So how do we handle that? Because here you had a visa and you're not in this country, but now you have the green card that says you are underutilized in the area that you are. So you do have that, but yet you can't become a citizen because it's 8 to 10 years or longer in the process. So then at which point are we the immigrant or we are on the path to become a citizen?
So from a Medicaid perspective, it all comes down to what your status is in SAVE. And there's an entire list of immigration statuses in SAVE that make somebody eligible for Medicaid upon entry to the country. There are those that have a 5-year waiting period. And then there are those, and I can confirm this, I believe there's a very small subset that you're never eligible for Medicaid, even though you're here legally. So Medicaid has kind of a whole array of It really depends what so you could potentially be here on a visa and still not qualify for Medicaid, even though you're here legally. It all comes down to what your status is in SAVE and what the current regulation says, which will be changing by October 1 of next year, of whether you're eligible for Medicaid or not.
Okay, so then in this case, the present administration now has indicated that maybe the employer is going to have to pay a large fee now in order to keep this person in this country in that H-1B or your green card status. So then how do we handle that situation?
Really that, again, that really won't impact, Medicaid. I mean, whether an employer has to pay, dollars to have a person get a visa to be here, from a Medicaid perspective, all we're looking at is what the code is in SAVE and whether that's on the list that says they get Medicaid or not.
Representative Sutton?
Thank you, Madam Chair. I'm afraid I might know the answer to this question, but I wanted to get confirmation from you, Christine. Am I understanding it correctly that it's not until HR 1 that we even check whether or not someone is receiving Medicaid benefits in another state?
No, we've been doing it with the Paris report. Well, KDHE's been doing it with the Paris report for years. There's just a lot of issues, and I think the Inspector General pointed out, there were even instances when an eligibility worker didn't necessarily follow up on the information. And so we're trying to create an automated process to avoid those types of situations. So what we're trying to do is take what the Inspector General pointed out, try to find a solution other than Paris because of its limitations that make it faster, but more automated as well, because you don't want to administratively create a lot of burdens and have staff time and costs there as well. So yeah, we're just trying to really respond to some of the findings and make it a better process.
See, and that's kind of the issue that I have. We know that there's flaws with the Paris system. It seems Medicaid's been around a long time. It seems to me that this is the sort of thing that's kind of a first step. Make sure we're not serving people in 5 different states, with our program. Why are we just now wanting to solve that problem?
I can't speak to why people before me, did or
more for myself.
I think there's a couple of answers. I think number one, as you go back in time, there wasn't like the PCGs, and there weren't these other companies that have really kind of gotten into this market, if you will. I don't know what quite to say, but offer these solutions that were an alternative to Paris. I think for a long time, Paris was it. And then I think it really does come down to I don't, again, want to say why people do or do not do things, but I will tell you in the Medicaid space, there's lots of issues every day. And I think people try to prioritize, what they maybe thought was the most, important. And we heard, what the Inspector General said, but as well as very much the concerns of the legislature about folks being enrolled in multiple Medicaid programs. So we bumped it, to the top of the list or close to the top of the list and said, we got to figure this out.
Committee, we're running about 15 minutes behind, so we're going to move ahead.
Okay. This next one is I'd mentioned it earlier, this is just to give you some background information on the continuous caretaker eligibility. So again, right now we have, as of August, 33,386 caretaker adults who would lose the continuous eligibility. Kind of put in there for a household of 4, the maximum annual income for this population is $12,228. Again, we aren't sure if it will be December 31st of 2028 or earlier. We're waiting for follow-up guidance from CMS on when this will actually go into effect. And we really should have had that slide up earlier. All right, the next slide, this is a little bit of good news. So we just got notified of it's time for the annual update to our FMAP rate. The official briefing will be published in November, so I didn't put a dollar figure in here because it could change slightly. But based on what we were initially notified, our FMAP is going to go up 1.83% in Kansas. So anytime the FMAP goes up, that's positive for
So
Kansas.
could you tell us, we don't have a dollar amount, but that percentage?
1.83%.
1 point, it's
it would
going
put
up
it-
1.8, and what is it now?
It's 61, just a little over 61%. So it's, and as soon as these numbers come out, we'll get it.
So it'll go up to about 63%.
Yep.
Okay, thank you.
All right. So this was, we were asked to kind of provide some data kind of around Medicaid, trying to look at a little bit of demographics as well as FPL ranges. So I know this slide is really busy, apologize for that, but of course Medicaid can never be simple, I think. So you can see, again, our largest enrollment group is our children ages 6 to 18. Their FPL is obviously 0 up to 133% of the FPL. And then in CHIP, obviously the ranges pick up after that 133%, and you can see the breakdowns there for our CHIP members that pay no premiums, and then for those that do with a cap at 255% of the federal poverty level. A couple things I want to point out here. You'll notice like in our 65 and over and the HCBS and long-term care, you'll see non-applicable for the FPL range. When you get into eligibility for our elderly and disabled in long-term care, it isn't just an earned income test. There's a lot of disregards. There's a lot of resource allocations. There's varying eligibility ranges. So it isn't as clear cut as it is for basically our caretaker medical or our children, which it's truly a range. I mean, if you're at 134% of the federal poverty level, you're on CHIP, you're not on Medicaid, kind of period. When you get into some of our other categories, it gets a lot more complicated and there's a lot more factors involved other than just income. And then the other thing that I will point out, you will notice for CHIP, we do have one member who is just getting ready to roll off. They just happened to be at the time we were finishing unwinding. They were pregnant, so they got CHIP coverage continued while they were pregnant, and then they get the 12 months continuous eligibility after that. And then for the 19 to 20-year-olds, you'll see 222. Most of those are going to be 19-year-olds. So in CHIP, the month you turn 19, you roll off at the end of the month. So there's some overlap there where you're technically 19, but you're still on CHIP. So any questions on this chart? I know it's very busy.
Do you have another chart that would, because this indicates the number of people that fall into each category, which is very helpful, but we know that the largest share of the cost is not necessarily with the children. Will you have a slide like that that gives us that data?
We can provide that to you.
That would be very
but the split is really about 80-20. The long-term care HCBS populations make up about 80% of our cost, even though they're only a small fraction of the enrollment. But we can get you that breakdown of
Thank you.
Yep, by those categories.
Please continue.
Yep. This is a follow-up. This has been a very not easy situation to resolve. So this is our sedation dentistry, especially around our mobile anesthetists. So I know you've heard from Dr. Glasgow several times. Again, this is just kind of an overview of what options are to the state, which I will say right now, none of them are great. The primary driver of why this is so difficult is the code structure. The ICD-10 codes have not caught up with the fact that we have mobile sedation dentistry. So they have to use the same codes that other, if you go to an outpatient surgery center, that nurse anesthetist would be using. So there's not a code that would accommodate for their unique expenses. So we looked at the code that they bill the most, which is 00170. You can see here what we, on average, for 120 minutes, the MCOs are currently paying $734. The issue that we have is we are very close to the Medicare threshold for this code. The rate is set on this code by Medicare. We have about 37 $2,000.70 to play with, which of course is minimal considering that they really would like this code to go up to $1,900 to accommodate their expenses. There is a modifier that we could add onto the code that could be specific to folks providing these sedation dentistry services. But again, those typically range around $200 to $300. So now we're talking, you know, at the high end, about $340 per billing instance, again, significantly below the dollars that they have been requesting to cover some of their unique cost and setup. The only other option really available to the state is we can do state-only funding. If you don't want federal match, I mean, really there's a lot of latitude provided to the states. Of course, you can see that does carry a pretty significant SGF. We could do a combination. We could increase the code and do the modifier and look at differentials with state dollars, but really there is not a good avenue to get to the dollar amount that they are requesting, and I do very much understand they have a lot of uniquenesses to them, but unfortunately the codes aren't aligned right now. Any questions on sedation dentistry?
Yes, Representative Bueller.
Thank you, Madam Chair. And I know this was a big topic in the last session and pretty passionate about it. How do you pursue getting a code specific to mobile anesthesia, or is there any work happening to do that?
So that has to be done at the national level. I do believe, I don't have a timeline, but I do believe that is being looked at, not just specific to dentistry, but I think mobile services in general. There's some movement there, but I have no idea on a time frame, and unfortunately, we really can't influence that.
Yeah, I understand. I just didn't know if you had any insight to anything that was going on. I appreciate it. Thank you, Madam Chair.
Thank you. Now, please go ahead.
Okay. So the next one is, I know you had some of our EMTs come in and talk about reimbursement for emergency medical services. So there's like four components of this that KDHE is currently working on. The first two that I'm going to talk about are much shorter term items. The first one is it's adding a code. It is an existing code, A0998. What that allows for is an EMS provider to be reimbursed if there is no transport to the emergency room. So that would be the patient and the EMS provider agreeing that the transport is not needed, and then they could receive a reimbursement for that. We are right now looking at other Medicaid states that cover that code to kind of get an average of what they reimburse for. We will obviously do this as a cost savings, because if we're not transporting to the ER, obviously that would be a lot less expensive. The second item will be a little bit more work. It would allow for reimbursement to transport other than the emergency rooms. So, if I needed to go to a crisis behavioral health or mental health type facility and urgent care, we have to look at what those appropriate settings are, what the criteria is to make that determination. Would we need to telehealth with a licensed provider to help make that determination? So it gets a little bit more complicated, but we are working on potentially allowing some reimbursement, again, learning from some other states that already cover that in Medicaid. The last two I'm going to cover on the next slide. These get a lot harder, but things that we are working on is, so one item is allowing the responding paramedic to provide some basic stabilization service. Could be administering of insulin, could be just some minor services that they could provide. Obviously, there's be a lot of work around what is appropriate under their scope of practice. Would telehealth be required with a licensed, physician in order to administer some services? We would have to work with CMS, because CMS has indicated some concerns with fraud, waste, and abuse. How do you know the service was actually rendered? So again, I think this is very much worth the effort. And so we are engaged with the EMS providers as well as CMS. And I think this is worth pursuing, and we will bring a concept forward as we get it developed. The last item that we're working on is some states allow EMT and paramedics to do home visits. These are typically around what they call frequent flyers of the emergency room for non-emergency reasons. There's fall risk in the home, but they have the EMT go in and do a home assessment to determine is there fall risk, maybe their prescription medications are kind of messed up, maybe trying to identify why are we having these non-emergent use of the emergency room. Again, you can see a lot of the same issues as above, the involvement of a licensed practitioner. We also believe this might have to be reimbursed through our electronic visit verification system, which would be a big change for EMS providers around billing. So again, this gets a little bit more complicated, but we continue and will continue to work through this because again, if we can prevent non-emergent use in the emergency rooms, that's always a positive. All right, and with that, that is the end of the EMS side of it, if anyone has questions. Okay. All right, the next one is, this is kind of follow-up to, part of this will be follow-up to an earlier conversation on the audit that the IG did, but I think I mentioned to this committee before that prior to implementing of KanCare 3.0, we went through a reorganization in Medicaid with the goal being to get our clinical team away from a lot of the policy work and fiscal analysis and all those non-clinical activities to let them focus on utilization management, prior authorization, oversight of our MCOs. So one of the first items that they have been working on is a review of our prior authorizations focusing on services that are under $1,000. Again, they give an example here of a colonoscopy. But again, looking at what is the benefit to the member if we do prior authorization, to the provider, what's the benefit to the state and to the MCO. Looking at those that have a 90% of approval rate. Again, if you have a high approval rate PA, it's standard medical practice, it's a low cost. There's probably more cost in doing a PA than not. So a lot of work by our clinical team in those areas. And now they are actually completing their first on-site audit review of our MCOs. And so you'll see the first bullet there. As Mr. Anderson mentioned in his testimony, KDHE had actually requested that audit of the MCOs. We had heard some complaints from the hospitals. It's hard for us when you get one-off complaints to really understand what may be happening. And again, our clinical team and now the CMOs at each of the MCOs are working through that list of recommendations and, where are changes needed. I think there's opportunity for improvement there. I think there's going to be some areas where it's our state level policy that may be causing some of the issues. So again, they're working through that with the chief medical officers to address some of those findings and make this process better. But I will say prior authorization in this area is also important. So, but we got to find the right balance. What's that right balance between the two? The other thing that they're really looking at in these audits is compliance with state and federal coverage, making sure they're applying state level policy correctly and uniformly. We do hear that a lot, that sometimes there can be differences. A lot of work going on around EPSDT. In lieu of services, home health, and DME are the areas of this first audit of primary focus. Couple things I'll mention specific to DME that they're working on is currently we do not have in our policy a rental cap to ensure that rental reimbursements do not exceed the purchase price of the piece of equipment. So obviously we're working on putting a policy in there, and then there are several DME services that historically have always been manually priced, and over the years, CMS on the Medicare side has set reimbursement rates for those DME services, and so we are looking through that list and will convert many of those over to a set reimbursement rate instead of being manually set, because obviously manually setting reimbursement it's very time consuming and administratively burdensome. And then we're also looking at removing prior authorization on DME services. I think last Bethel, we talked about the proviso, and I said if the proviso did not continue, we were looking at 500 and below of no prior auth. We're now up to 1,000 because we found the approval rate on anything underneath 1,000 was well over 90%. So we believe that's a good threshold. And that is things on the MCO audits, if there's any questions. All right, and the next two, I'll go quickly. This is standard information. I will point out on this first slide, our number of over 45 applications has dropped significantly. We used to, back before unwinding started, we would average around 1,300. We are now usually in the 600s and 700s, with many of those being in the presumptive disability area. So those are folks trying to get through the Social Security disability process. There's a way that you can become eligible for Medicaid while you wait for that process. But it is a disability process that we have 90 days to complete. But again, our team has worked very hard to bring those numbers down. I know that's important for our providers and our members. And then the last slide is just our call center metrics. Again, you can see that they continue month over month to perform exceedingly well. So really no issues to report there. And with that, that is the end of my, oh, nope, sorry. I lied. And it's good news, and I wasn't even going to tell you. I just wanted to point out that last month we were recognized by the IT Solutions Management. I had talked to this committee before about what we call our proactive communication. It's a new platform that allows us to communicate directly with members electronically. It has shown and continues to show a lot of improvement. We've got a 10% increase in reviews being returned on time. Late reviews cause problems for us, cause problems for the member. Unsigned reviews are now below 1%. So we were recognized by this group for the implementation of that technology. And I promise with that I am done.
Thank you very much, and thank you for your presentation. Yes. We are now committee going to be moving to our next conferee, which is Secretary Laura Howard.
Thank you, Madam Chair and members of the committee. Laura Howard, Secretary for the Kansas Department for Aging and Disability Services. I'll kick this off very briefly. I know you're running behind on time, so I'll get this to my team members. I'm excited that we'll be able to present to this committee as well as we just did presented to many of you who are also on the Health and Social Service Committee, just the broad array of work that's been going on around the IDD modernization initiatives. I hope those of you on that last committee saw the tremendous progress that's been made with partners and stakeholders in making that progress, and then how that will connect as well to our ability to launch the community support waiver. You'll hear more from my team about that, and we'll try to be expeditious on that today, given that we recently participated in that. I did want to mention to this group that the rankings for Mental Health America, which ranks mental health systems across the country and mental health, that we improved in those rankings from 22nd to 17th, and we were ranked 51st in 2023. I bring that up to this committee in many ways just to say thank you. You really need to give yourselves some really applause and a pat on the back, because so much of this relates to your support for a lot of initiatives, funding, enhancements, the development of the CCBHC system across Kansas. And I was at a national Medicaid conference, was talking to some other states who were trying to move that through, and I was reminded again that we are one of just a handful of states that have CCBHCs in every county in our state. So that, the funding in crisis, those things. So I really just say that to say we obviously have more work to do in behavioral health, but I just want to thank you, because I think your focus, your attention, and your investment has made a difference in terms of where we stand in the national rankings. This Friday, we have our Governor's Conference on Aging in Manhattan. It's the first time that this conference has been held in about 15 years. So we're really glad to kick that off. As you know, there are so many issues relating to aging. I hope to see some of you there this Friday. And then I just wanted to make a brief introduction. Kim Reynolds is here. Kim, you might stand up just for a second. Kim Reynolds is our new Aging Services Commissioner at KDADS. We're really excited to have her. Kim has worked in the state system before in KDADS and in SRS, but she's also worked in other venues, most recently at SAMHSA at the federal level. Kim has a great background in gerontology from an education perspective, and in fact, in her most recent role at SAMHSA, she was the national lead on issues to do with aging and mental health. So again, we're glad to have Kim join our team as our Aging Services Commissioner. We were sorry to see Dave choose to retire on us, but again, we've got a great person here. I don't have any federal updates that are really very significant since our last meeting. We're managing through the shutdown and various things, and I don't have any specific things, so I can stand for any questions you may have for me.
I don't know if you were listening, you were not in the room when I was addressing Secretary Stanek about the elephant in the room, which is, of course, the SNAP benefits and what the federal government is asking for, which when I researched that didn't seem to be out of the ordinary. Could you address why it is that you've not given the federal government the information they're requesting?
Yeah, thank you, Senator. I can address that. So under the SNAP program is managed differently and it has different federal provisions regarding confidentiality. In existing federal law, there are a number of ways in which SNAP data is allowed to be used. When the federal government asked states to begin providing data back to them, they added an additional use of that data that, in our view, in our legal view, went beyond the scope of the federal law. That's the basis by which we're not doing that. You know, and as you may know, 25 states entered into a lawsuit against the USDA, and a judge has entered a temporary restraining order on behalf of the states with regard to not using the data in that fashion. And it really had to do with being able to share the data more broadly than for reasons of administration of the SNAP program. You know, we are working with our payment processor and with Accenture to make sure that we have the data ready as this issue works through the process. But again, all I'm seeking to do, all the governor is seeking to do is to follow the law as we understand it. And our issue is with this particular purpose that goes beyond the specific parameters that are called for in federal law. So that's the reason, Senator. I mean, it's as simple as that. I mean, where we are in the process, you know, is we have filed an appeal. You know, the federal agency, it's kind of gone through, you know, the very formal process. They've issued a potential disallowance on the administrative side to us. We have filed an appeal with the Federal SNAP Appeals Board that stays any application of that penalty while the appeal process is in place. We need to provide our documentation related to that but by later this month, although I think the shutdown delays that further, but we intend to turn that in by the deadline on the 22nd. And again, we will be ready to provide the data no matter what the decision is. But again, that's the legal review that we've had. And again, I have no issue providing it for the purposes called out in federal law, but our legal perspective and that of, you know, half of the other states in the nation is that the request goes beyond federal law. That's the only reason, Senator.
What specific data are they requesting that is beyond name, address, birthday, you know, the usual?
I mean, they're asking for all of the personal identifying information of all of the every applicant, every recipient, and every household member of individuals who may be on SNAP. So that could go beyond actual beneficiaries. But again, our issue is not so much with the data they're asking, it's for the use that they intend to use it for, and that provision, when they put out the notice, just goes beyond federal law. And my view, and I think the view of the governor, has been that I'm concerned with putting the state at risk of liability of sharing private information. We believe it violates the Federal Privacy Act, and the state having some liability for having done that. So again, I certainly will comply with what occurs through the legal process. I don't have any agenda beyond just seeking to follow the law, Senator.
How do we know the purpose for which the federal government would use the identifying information?
This has gone through a couple of stages, but after an initial pushback from many states, an initial filing of initial litigation, the USDA stepped back from the request. They then went through a formal process where they talked about creating kind of a system of record. They filed that within the Federal Register, and I can share that with you, Senator. And so within the Federal Register, then they detailed the data that they wanted, and then they detailed like 9 uses or something like that that they would make of the data. 8 of those followed exactly the federal law. The other one went beyond what the federal law relating to the SNAP program allows. And SNAP has very, very stringent privacy restrictions. We have to enter into so many, detailed legal documents, even between ourselves and USDA, for the things that are even shared for quality control perspectives because of federal law. So again, that's all detailed out in the Federal Register. I'd be happy to share that detail with you, and the piece that we see that goes beyond what is an existing federal law.
I think it would be good for us to see that. And finally, we know that for years there have been some overspending on the SNAP program in the state of Kansas. I think it's like 9%. What have we done to address that?
Yeah, thank you, Senator. I think you're asking about the payment error rate,
yes.
Which again, that's not a measure of fraud or abuse. I mean, there are some other things related to fraud or abuse that we, have active work on with our own fraud investigators and things like that. So the payment error rate is really a measure that it could look at either overpayments or underpayments that happen within the context of eligibility determination. Those can happen as a result of errors by the client. They can happen because of errors by my caseworker. So again, those numbers have gone up and down. Yes, our rate is, as you said, it's just under 10% now. We're doing a lot of things to address that. Most recently, the first, as all states do, is really trying to identify what are those facets where we see the most errors. And SNAP eligibility it's very complicated. There's a detailed documentation that happens, and we've identified, a couple of different areas. One has to do with the area of shelter costs where we find some of the largest errors. So one of the things we've done that just went into effect October 1, which is new, is we've added additional verifications at the front end related to the shelter standards. So this might actually end up resulting in some delays in application acceptance, and that it will take longer to verify that. But most states have had some versions of a simplified eligibility on that component, but that's hitting us a lot on the payment error rate. So we put in a new policy where we have more detailed verification there. We've also enhanced our internal quality control, quality assurance, where we're reading and we'll be able to measure by each team and each caseworker numbers of errors. And in fact, in the last 12 months, the share of errors attributed to our staff has gone down. So it's now about 65% client, 35% staff. It was about 50-50. So we're making good progress with our staff. We also are we just brought in a consultant through I think it's called Human Services Group, that's going to do a kind of a 3-month deep dive to see what other pieces might be helpful in that. And then we're also looking at some automation pieces that might take some of the kind of errors that can happen, out of the kind of the hands of workers, even the conscious of using some AI. I was just at a conference actually with Secretary Stanek related to Medicaid, but I was talking with several other states there who face, significant risk of penalties in coming years. And again, we were all speaking together about, just solutions, what we're doing. But, it's really, frankly, it's really hard, granular work. It's very detailed eligibility. Things can be as simple as you had a 17-year-old son who was, working part-time at Dillon's, and that doesn't count as a minor on the income. The son turned 18, that didn't get reported. So for that, and then when you found that in the quality control, that income should have counted in that month. And so it's very, very detailed. I mean, just very, very granular. We are being very, very aggressive on this. No doubt about that, Senator. We are measuring and monitoring that. We'll continue to be reporting to the legislature about that, I'm sure, throughout the session about our progress.
Thank you so much for addressing that, because again, that's been in all of the news, and I think that we needed to hit that first. I tell you what we're going to do, for those of you in the room and committee members, we're going to go ahead with Scott and Lacey, and then we'll try to get back on track. And Michelle, if it's okay with you, we will wait till after lunch for your report, and Andy as well. Okay,
All right, thank you
so
I'll
much.
turn this over to Scott then. Thank you.
Thank you.
Thank you, Madam Chair. I'm going to hear a lot about that back at the office, that I get to go and everybody else has to wait until after lunch. But Scott Bruner, I'm the Deputy Secretary for Hospitals and Facilities. I'm actually presenting for Lacey as well today. She's unavailable, so you get kind of two for one. So in the slide deck that the Secretary was speaking from, the first topic I've got is an update on the South Central Regional Mental Health Hospital construction. Again, we started construction on a 104-bed psychiatric hospital in February. We expect to be complete by October of 2026 and open and accept our first patient in January. Where we are so far in the project, I'll show you some images here in just a second. We've spent the $25 million of Spark funding that was allocated to Sedgwick County for that project. There's other state money that also goes into the project as well, but the Spark money is fully obligated. So that was a key milestone in the project. We've also passed in the session last in 2025 the bill to create the agency as a separate state hospital with the authorities that we need, and that's triggered our submission of a budget for 2027 into the governor's budget review process that'll reflect the half year of full operations of the hospital. So a couple of key milestones along the way for that project. There is on slide number 5 a couple of images of the hospital construction. The one on the left is where we were at the end of May. This is should have taken it from the same perspective, I suppose. But so this is shows the concrete pad for the foundation being largely completed, and part of the gymnasium's up. That's the tall part in the center. The picture on the left is from a couple of weeks ago from the opposite corner of the site. So you can see the parking lots laid out. The second story's on. A couple of the patient units are enclosed, and the roof is going on. So we're making good progress on the project there with the steel infrastructure and getting the construction completed. Another item I was asked to give you an update on is for our reimbursement program for patients that are waiting for state hospital admission. I think I've spoken to you about this before. In 2023, we were directed and provided about $5 million to reimburse healthcare providers, law enforcement, and other county entities for unpaid costs if a patient's waiting for admission to a state hospital. They've been accepted, but we don't have the bed space And so they're waiting either in an emergency department or some other location for that admission. We've been processing those reimbursement requests from hospitals primarily for the last couple of years through September 2026. We've paid out a total of 3.3 or almost $3.4 million. We've been talking to the Hospital Association about ways to encourage more hospitals to use that program, talked about the process that we're using, and if there are ways to simplify that. So we should see that tick up a little bit here in the next over the next fiscal year. But it's working well, and for larger hospitals that have a lot of volume of patients that wait, primarily in urban areas, there's a lot of use of that program, and we've heard positive feedback. On the kind of deja vu list of topics, contract staffing at the state hospitals, you asked for an update about our use of contract labor to fill in some gaps in our staffing. Again, we've talked about this before. The couple of slides that, again, we talked with the Special Committee on Health and Human Services just a couple of weeks ago, over a couple of days, so several of you have heard much of this information before. But just trying to give you some perspective on what we've spent on contract labor and what our projections are through this next budget cycle. So on this slide, it shows for fiscal year 2025, both for Larned and Osawatomie State Hospitals, at the top, what we spent for our own staff, direct care staff, registered nurses, licensed practical nurses, so our FTE positions. So for Larned, we spent almost $15 million on our staff costs. And then we added to that $42.3 million of contract labor, again, to supplement our staff for a total of $57 million. At Osawatomie, it's on the next table. We spent $6.8 million on our staff and then 14.8 on agency staff. The special committee asked us what would it cost, or what would the cost difference be if we filled all of our state positions as a point of comparison. So that's what's in the bottom part of both of those charts. If we filled all of our vacant positions at Larned, that cost would be $31 million, and at Osawatomie would be almost $16 million. Again, that's trying to reflect that our agency staffing costs are significantly more expensive than hiring state employees. But again, the agency staff they're available. We're able to fill those positions through the contracts. So we'd have to figure out some way to find those staff to fill the state positions in the alternative. Just to show you the history of what you've added to the Larned and Osawatomie budgets over the last several fiscal years for contract labor, and then what we've actually spent on contract labor over the last 5 or 6 fiscal years, 7 fiscal years, so you can see where that's moving. In the budget request that we've submitted to the governor's office, we've requested about $32 million for Larned and $7 million for Osawatomie to be the equivalent part of this, the contract expected costs over the next fiscal year to keep the beds open that we have. That was a little fast. Again, I was trying to save you some time, but
That's
happy
okay.
to take questions
Thank
at
you.
that point.
And we have a question from Representative Carpenter.
And we heard a lot from you, and I appreciate that. So on this one chart here, contract staffing, the state hospital budget update. So I'm looking at Larned State Hospital, and you've got registered nurses, licensed practical LPNs, and MH DDs. Then you have agencies. So we have no CNAs on our staff. I mean, I'm just trying to compare apples and apples here. And you have patient care staff here, 36, and then CNAs 138. So we have no CNAs on our staff.
As state employees, no.
Okay. That's what I'm trying.
So,
and no personal care staff as state employees either.
The equivalency there is with the mental health disability techs. That's our state classification for the equivalent role of the patient care staff, the PCSS.
And I just think you ought to call that the same. It just FYI.
Sure.
You see what I'm saying?
I do.
Because it gives a look of not having anyone. They're just called different, but they're the same people.
It's a great question. I apologize for not covering it more. So in the contracts that we use to recruit agency staff, those state contracts that are out and available, they define the kinds of employees that the staffing agencies have to provide. So registered nurses that's a license type, that makes sense. Licensed practical nurse also makes sense. CNA is another certification that is comparable state to state and something they can go out and recruit people for. It's a skill set that's beyond what we need as an MHDD tech, but it's available on that contract. And then we've added PCSS to that state contract. So there's a classification for those agencies, similar kinds of people, similar kinds of requirements, so they can go out and recruit, but they are the equivalent
And I
position.
appreciate that.
Yeah.
I just, when I'm looking at that.
We can make that clear.
Anyway, thank you.
For apples to apples, absolutely.
Senator Petty.
This is just a quick question. On that fund for reimbursing back to counties and hospitals, is there a set amount of money in that fund?
There's a $5 million annual appropriation.
Thanks.
I don't think we can move ahead to Lacey's presentation.
So I am not Lacey Hunter, but what she was asked to talk about was an update on surveyor positions. So we've been trying to work to add more surveyors to our team to help us investigate complaints, make sure we're out and doing timely surveys for both our state licensed facilities and facilities that are certified by CMS. One of the things we've tried to do with that is redistribute funding from vacant positions to raise the salaries so that we can recruit nurses at a higher wage. And we thought the fairest way to do that was to identify how many total nurses we needed for our survey team, and then delete the remaining positions or a number of the remaining positions, take the salary money attached to those positions and redistribute it among the existing staff or people that we were going to recruit. So we got approval from the Department of Administration to do that after several rounds of negotiation, and appreciate their help on that process. We started with 51.5 positions for nursing surveyors, and 28 of those were vacant. With the approval that we got from Department of Administration, we eliminated 15 of the positions, and then the remainder of the vacancies we raised from $60,000 to $67,000 if you're a registered nurse. You have to have the registered nursing license. And then we distributed some of the rest of the money over our existing staff so we wouldn't create compression. We've started posting positions at that wage rate. We've seen a few applications, but we're trying to advertise that a little bit more broadly so people know what we're advertising and where we are. The other item that we talked about with the special committee, but it's also come up through the long-term care ombudsman's testimony to this committee and some other places, is about using a multidisciplinary team of people so we don't just have to look for registered nurses. We could hire people with other professions or other backgrounds to be part of the survey team. So we provided here on slide number 12 what the federal requirements are in the state operations manual for who can be a surveyor and what they have to know how to do. And there are provisions in there for other kinds of professions or other backgrounds, like hospital administrators or nursing home administrators, social workers, people like that. And Lacey's part of a national group of survey directors like herself, and she's talked to them about other types of professions that other states recruit. So we're working on what that would look like. There are a couple of issues with hiring non-nurses into those roles. A lot, and we talked quite a bit to the special committee about this. Our registered nurses are exempt employees, so they are salaried and they can work as many hours as they need to complete their tasks. Some of those other professions or license types or people with other backgrounds, we'd have to, maybe non-exempt, so they would be limited at 40 hours a week of work, or then we'd have to pay them overtime. And I think with some direction from the special committee, we need to investigate that more of how we could cross that threshold. And so we're working on and can bring back kind of our plan to recruit other types of professions into the survey teams. There has to be a nurse, or has to be a registered nurse on the survey team. So we're always going to need nurses, but see if we can incorporate some other professions as well. And then the last topic that I had was an update on rural emergency hospitals being licensed as skilled nursing facilities. You had heard over the last maybe 18 months or so from some rural emergency hospitals that were trying to move forward in their classifications with other federal requirements and ran into some hurdles on our side of not being prior licensed as a skilled nursing facility. So you passed last year House Bill 2249, which had a provision that would allow the Secretary of KDADS to waive the physical environment requirements for a skilled nursing facility that's becoming part or is part of a rural emergency hospital. That would resolve the issue and clarify that the Secretary has the authority to offer that waiver. Since that bill's been passed, we haven't received a request to do that. We're not in a waiver's they've got to ask us first before we can issue something. But so that's where we are with that. But the statute's in place and we're ready to issue that waiver upon request from a rural emergency hospital. Madam Chair, that's all of the 2 items that I had for Lacey and myself.
Very good questions. Yes, Representative Ballard. I keep wanting to make you secretary.
Thank you. Thank you, Madam Chair. I appreciate it. All right, so you raised the salaries from 60 to 67.
Correct.
How competitive is that actually? What is the going rate? Or the market rate?
For a registered nurse that's working in a survey environment, so they're not using their license to provide direct patient care, we think that's pretty close to what Department of Administration determined the market rate would be for a surveyor role filled by a registered nurse. If they were registered nurses working in a hospital or clinic setting, they're going to make more money than that as a starting place.
Okay.
Plus they may be hourly, and they could earn overtime.
So what's our other problem with surveyors? Because we've had problems with surveyors for a long time trying to hire them. Is it not just the market, but a shortage of them, or?
There's a shortage of registered nurses in all kinds of healthcare settings doing direct patient care and other things. This is a primarily administrative role, so not all nurses would want to be a surveyor. And then for those that do, it's a pretty tough job. They're on the road 4 days a week, working outside of their home, staying in hotels a lot. So it's not you're not a telehealth nurse at a desk on a camera. This is it's pretty intensive work, both to do surveys and do complaint investigation.
Madam Chair, my last question, are we competing with contract nurses?
For a survey role, that I don't know. We don't have any contract survey nurses that we work with at KDADS. KDHE uses a vendor to supplement their survey team on the acute side. But we could check into that, what the rate would be if we were going to use some of the contract companies that help states get surveys completed. We could tell you what that rate would be.
Thank you, Scott. Thank you, Madam Chair.
Absolutely. I did want to mention that Senator Peck is in 2 committees today, so he had to leave to go to Tax Committee, but he'll be back tomorrow. Committee, we are in recess for lunch until 1:30.
Your mic's on. Your mic.
To begin, we're going to start with Michelle Hayden, with the Commissioner for Long-Term Services. Thank you, Michelle, for letting us carry over until the afternoon.
Hello? Okay. Okay. Mm-hmm. This is page 6. I'm trying to get it to, it's not advancing. Okay, there we go. A little bit far, but page, just go back to 14, yes. Thank you, everyone. I'm Michelle Hayden, the LTSS Commissioner for Long-Term Services and Supports. These are our current HCBS waiver enrollment numbers, at least of August 2025. So the projections now show, if you can get back for some reason. Okay, projections show potential new waiting lists for frail and elderly, technology assistance, and the brain injury waivers. The agency's FY26 enhancements okay. FY26 enhancements request was not granted by the legislature to fund additional capacity for these waivers and creation of waiting lists. A wait list mitigation strategy work group has been formed with MCOs, KDADs, and KDHE. An initial meeting was held July 9th of 2025. They had meetings in August. Brain injury waitlist mitigation group was initially held 8/6 of 25 and is meeting again next week. The frail elderly waitlist mitigation group will be meeting later this week. The technology assisted TV waiver program manager hosted a TA waiting list mitigation group on 8/1/25. There was also an additional meeting hosted with the MCOs to discuss waitlist mitigation and other services forms needed.
Representative Bueller has a question while we're waiting for them to get the IT.
Yeah, sure.
Thank you, Michelle. And I should know the answer to this question, but when we say we've got a projection for wait lists for those categories, is this just all about the money? I mean,
Yes, we have to have appropriations in order to prevent a waiting
it's
list.
not a unique set of circumstances that necessarily exist with IDD where it's, you can't do one without looking at slots. And so we're at the beginning.
Right.
Is money, okay?
Yep.
Right.
We do have waitlist mitigation groups to look and see if there's other things we can do.
Okay.
Basically, it's, we have to have the state's portion of the funding to draw down the federal dollars.
So if at some point, if we knew what the mitigation groups were discussing, talking about that, or if you can talk about it a little bit, that would be helpful.
Yeah,
At
I
some
could
point,
probably.
I don't want to derail your presentation, but I'm curious, very curious.
Yep.
Thank you. Thank you, Madam
Yep.
Chair.
So these are the estimated shortfalls as of June of 2025. As you can see, our largest shortfall is for the frail and elderly waiver. And we do predict that we will have a waiting list for that soon. The brain injury and TA waivers are not near as large of a shortfall. We're hoping to mitigate that this year and prevent going forward with a waiting list. So this just is an update on the IDD offer rounds. So in January, we sent out a total of 200 offers, 150 accepted, active on the waiver, 124. Total offer rounds sent in June were 193, 130 accepted, active on the waiver, 104. And just last month, we sent 279 offers out. 97 so far have accepted, and people are not yet active. They're still going through the process of the application, but we expect those numbers to rise. I'm just going to go over a little bit about the direct support waiver, direct support workers career ladder project. This is the career ladder that we've been working on as far as Kansas Direct Support Workforce Development. And we're promoting DSW career as a stepping stone into advanced health and social services occupations, recruiting and retaining DSWs in the field. There's been a marketing campaign, career fairs, social media campaigns, provider directory and matching service registry, labor market analysis to better understand the needs and trends for the direct support worker. Developing the career ladder to promote growth and enhancement in the DSW career, promote the DSW career as a stepping stone, and so forth. It's a multidisciplinary online training program freely available to DSWs statewide based on CMS DSW core competencies. Stakeholders engage development and testing process. We host it on the train and supported by a website. We have 28 modules total with 8 modules that are now live. We're provisionally accredited by NADSP with full accreditation application in process. KDAD's applied for, and it was accepted to a state peer learning collaborative through ACL in an effort to lead the direct care workforce strategy centers to strengthen our direct support workforce. This ended in October of last year. We're now part 2 of the state peer learning collaborative state advanced lab in August of 2025, and they've awarded us 250 hours of technical assistance. I went over this a few weeks ago in in the Social Services Committee. Just wanted to highlight the Kansas Employment first pilot project that we worked with KU on. We engaged in, there were activities that this project engaged in, developed policy recommendations, build provider capacity, recommended data collection and analysis procedures. And so there were 4 entities that participated in a pilot. That was OCCK, Compass, Starkey, and Down Syndrome Innovations. We provided training and technical assistance strategies offered by the Kansas Employment First Project. There was self-assessment to identify technical assistance needs, development of an action plan, mentorship for organizations, Association of Community Rehab Centers, training and advanced certification through our training partner WISE, wraparound training for families and youth, data collection and analysis. And these are the counties that we were able to employ people in through this project. So, you know, this was a very successful program. As I had said before, that our purpose was to support the development of highly trained and networked employment support system across Kansas. The training and technical assistance offered builds on the success from the Employment First pilot model, where over 170 people with disabilities across 4 pilot organizations obtained competitive integrated employment, averaging $13.89 an hour and 22 hours a week. Key parts of the training and technical assistance included mentorship for provider organizations to provide high quality, community-based employment and community engagement services, development of Kansas-specific ACRE accreditation, technical assistance on a state level, and development of a data collection system. So then I'm going to move into our IDD modernization consensus work groups, and some of you have already heard this, but I'll go over this again. We came together with our stakeholders, including InterHab, families, and other entities, MCOs, to work on modernization of our IDD system. The purpose of that was to come into compliance with federal requirements. We got stakeholder input and readiness, implementation of the community support waiver. So our vision fell into 3 categories. The first was access. That was the community support waiver, and the MFEI, which is the new level of care tool that we use in the IDD world. Choice. These 3 projects are what we've been working on for choice. Unbundling of the day services, conflict-free case management, person-centered service planning, and for quality, service definitions, monitoring, and adopting the Enter RAI as a needs tool that all 3 MCOs will be using. So if we really look at it, our approach is under 3 key activities. Phase 1 was no dual service provision. So what we came up with the help of the work group was align with work group recommendations, map the current state and future state of what we're going to be doing with with targeted case management, communicate decisions and directly to key stakeholders, draft and develop only willing and qualified provider policy, and establish compliance monitoring protocols. Phase 2 is the consolidated person-centered plan. We have been told by CMS and by families that's very confusing the way we do things under managed care. The MCO develops a service plan, the targeted case management develops a service plan, and then there's just so much cross repurposing going on. And we want to consolidate all of that so that's easier on families and we're in compliance with the expectations for CMS. And the third phase is the unbundling of the day services. And we've been drafting selective service definitions, draft and submit review amendments for the CAP, for compliance, and review implementation plan options. So the phase one is no dual service provision. Providers permitted to deliver services in targeted case management, but not to the same individual. So you can either provide them day, residential, or whatever, or TCM, but not both. Only willing and qualified provider status for limited circumstances. So there is a provision that you can, if like for say in a rural area, there's only one provider, they do everything like TCM, day services, and residential services. That may be in that case that they would be allowed to continue to do that until we develop capacity in that area to provide separated services. Allows for multiple compliance pathways, aligns with federal expectations and modernization work group recommendations. So I should say we've been working really closely with our community partners on this. We're developing a policy with them as far as what is an only willing and qualified provider, and working with them on looking at all the options depending on where they are in the state. And I won't go through these, but when we did our work groups, we in March and April, we split up into 3 large work groups, and then there were 8 smaller work groups. And for 2 months, we met all the time with stakeholders, figuring out the way forward to meet the needs of the IDD system in order to be compliant with the federal regulation. So these are just a number of the key stakeholder feedback that we got. I won't go through and read those, but there's just, you can see that it was pretty complex and there was a lot of feedback. So for the consolidated service plan, this was the same situation. There was a lot of feedback on how we move forward with the consolidated service plan. We're still working through that. We have targeted case managers working with us as far as how we move forward with a consolidated person-centered plan. And mostly what we want to do is to ensure that families and people served have one plan, have one meeting, so that they are not confused by the system, and that they can work with their targeted case manager on those. So unbundling of day services, existing day supports to be replaced with new distinct service categories. This will increase choice and flexibility for individuals. Work group to begin drafting service definitions aligns with the HCBS settings rule. The work group has already been meeting. We've met, I think, 4 times now, working on the proposed definitions, making sure that they are in line with all the state and federal regulations and will pass CMS muster. These are just some of the things that we talked about, like streamlining billing codes, conduct feasibility studies, having non-standard hours for day services. And so there's just a lot of different issues we have to address while we're doing this work. So again, these are the phase 1, phase 2, phase 3, and we're working on all 3 of these at this time. They will each have their own timeline as far as when we'll complete the work, but that will all bring us into compliance with the federal settings rule. I can stand for questions.
Any questions for Michelle before we move on? Yes, Representative Carpenter.
Thank you, Madam Chair. So going back to slide 17, your wait list on the brain injury and the frail and elderly.
Mhm.
You used to have a slide that showed the numbers, the actual numbers of people that we're talking about, to use your projections.
Mhm.
You don't have that on this,
I don't. I have the number of people that are currently on the waiver.
and it showed, the growth of it, why you were thinking about.
Right. I think that in tomorrow's testimony, they'll be talking about that as far, for the budget.
So my question is, these budget shortfalls that you're looking at here, is it because of the number of people, or is it because of the spending going up on the people that we already have?
It's the number of people that are wanting a slot on the waivers. For the frail and elderly, the boomers are all turning 65 plus. So a lot of people are now eligible. A few years back, the protected income level was raised quite a bit, so more people qualify for the frail and elderly waiver. And we're just seeing, the growth of people that are turning 65 and older.
Yeah, I saw it. Your other chart was around 500 people a year. I think that was
Yeah,
the growth was projected.
something like that.
So, yeah, I saw that. So I was just curious if it was the number of people. But while have this, the frail and elderly waiver is critical for our state. I hope folks understand that these are services that keep them out of nursing homes. It's that simple. So that's what the frail and elderly waiver does. It's far cheaper to get them on the frail and elderly waiver than it is to put them in nursing homes, regardless. And then the improvement of quality of life is they're at home. So we need to figure that out. Thank you.
Mhm. Thank you, Michelle. And now we'll go to Andy. Andy Brown, Deputy Secretary.
All right. Thank you for having me here today. My name is Andy Brown. I'm the Deputy Secretary for Programs at KDADS. We have a couple of things that are just kind of other questions that were asked for that I'm going to try to provide program updates on. The first one is really around some of the timelines that we've discussed in previous meetings. So just as a reminder, we've been working with the MCOs around community care coordination with the idea of having a target implementation for pilot program starting in January. And then the Know Your Options Resource Guide is a senior resource guide that was approved by the legislature last year. We've contracted for that, and we're expecting to have the guide ready to be published and printed in the second half of this year. Then for the 1115 serious mental illness IMD exclusion waiver, we asked for a little bit of an update or overview of that. So an IMD is essentially an institution for mental disease. Some routine sort of examples of that in our system are our state hospitals, our nursing facilities for mental health, our substance use and treatment inpatient programs, our private psych hospitals, those types of programs. The IMD exclusion is a part of the federal Medicaid program that basically says you can't use federal dollars to pay for treatment for somebody that's in an IMD. So a waiver of that exclusion basically allows us, under the parameters that are allowed by that waiver, to provide reimbursement through the Medicaid program that includes that FMAP federal participation rate. So essentially, what we are doing right now is we're working on developing that waiver application for the severe mental illness side of this so that we can look at providing up to 15 days of reimbursement to providers that are providing mental health services. And then this one shows you kind of like where we're at with that. So we're currently drafting. KDADS is leading that and working with KDHE. We've engaged in some stakeholder engagement and revision that will be taking place over the winter. And then we're hopeful to have a final application submission in January of '26. And then hopefully that'll translate into a CMS approval that will allow us to start the program up sometime in the next state fiscal year. And that's kind of the end of what we have to talk about today. So I'll stand for questions.
Questions, committee? Representative Carpenter.
Thank you, Madam Chair. So Andy, how many people do you think that we would actually benefit from the IMD waiver?
I mean, I would say it would probably be in the high hundreds, maybe the low thousands. We process a lot of folks through acute treatment that lasts for a short amount of time. So most people that are going into a private psych hospital for mental health treatment are usually only there for a short amount of time, 72 hours, maybe 7 or 8 days. Very few people are there for long-term periods that would be over that 2-week or 15-day window. So I think a lot of folks that we're seeing in the emergency rooms and in the community crisis centers that may need a higher level of care can be routed to those hospitals, and then we could help cut that. Right now, our State Institute Alternatives program is paying for those services with 100% state dollars. So if we're able to shift and start using a federal match, it would be a savings to the state.
And I was mainly concerned, I guess I didn't make myself clear, as far as the state hospitals go.
So yeah, so for the state hospitals, we have a couple of hurdles to pass to do that. But for the beds we have that are eligible for Medicaid participation, we would be able to utilize that in like the Adair unit, for example. But we have to make sure that we've got all of our enrollment and stuff done for the Medicaid program for those beds to be eligible. And in some cases, our facilities are not going to pass the requirements for that.
So I guess 50 people?
Well, I would estimate that likely we would be able to use it for the majority of the acute patients that are going to be at the Wichita facility. And I think that's going to be, I would still estimate somewhere in the high hundreds in terms of the number of people that would go through that in a year.
In Larned?
I'm not sure that we would have anybody at Larned.
Okay.
But it might be a good question to follow up with Scott on.
Probably will.
Yeah.
All right. Very good. Thank you, Madam Chair. Thank you.
One second. Representative Bueller. Okay.
Thank you. I want to follow up on that question, Andy. When you say you'd have to look at the beds, are we talking about licensed or certified beds that needed?
I'm talking about like the actual like physical structure of the building, like the actual like we have to have ligament-free environments in order to qualify for Medicaid reimbursement. And that's something that we haven't been able to do in all of our facilities at this point.
Okay. Thank you, Madam Chair.
Thank you, Andy. Committee, next we're going to move to the next portion of our agenda, and we're going to start with Becky Fast. Becky, welcome to committee. Nice to see you. Becky, I just want to apologize. I thought you all had already been told the time. That's my error. So you'll have 3 minutes. All right. Thank you. The committee will have 1 minute for questions if necessary.
Sorry, being the first. So digital safety experts and parents have been sounding the alarm. Recently, Senator Josh Hawley held a congressional hearing in the Senate Judiciary Committee about the impact of these AI chatbots on our children. This congressional hearing, he had parents testify. One of the parents spoke about his son who seeked an AI chat box and told and relayed to that chat box that he was thinking about taking his own life. The chat box did not refer him to 988 or emergency mental health, but instead gave that his son step-by-step instructions on how to commit suicide. And when his son then said he was very concerned about his parents, the AI chat box responded, "You don't need to worry about your parents," and helped him write a suicide note. So at this hearing, also there were experts from the American Psychological Association that expressed real concern about the teenage developing brain and the impact on their social and emotional development and how their developing brain can be easily hijacked by these platforms. I know we have limited time. On the back of your testimony, I've listed some states that are taking action and have taken action. It is mainly about disclosure, that people realize that many of these apps have no human interaction. There is no licensed therapist. And some of these apps, they advertise that they are like an AI therapist, that they are there to provide mental health. But there is no human involvement. Many of them lack emergency mental health protocols. And so several states have said that these technology companies need to stipulate those disclosure. Recent Texas Attorney General has filed a lawsuit on the deceptive practices of these chatbots. I would like to say that AI has very useful administrative tools that social workers are using to create efficiency, and we'll be working with the Kansas Mental Health Coalition and be meeting with you. Thank you.
Becky, thank you so much, and we appreciate your testimony.
Okay, thank you.
Next, we have Jeremy Salisbury.
Good afternoon, everyone. I'm Jeremy Salisbury. I represent Special Anesthesia Services out of Derby, Kansas. Together with Advanced Specialty Anesthesia out of Lawrence, Kansas, we take care of over 8,000 office-based sedations in Kansas yearly, primarily serving pediatric and special needs patients enrolled in the KanCare program. Our teams deliver the complete package to these dental offices so that these patients can be getting cared in their communities. We provide the staff, the supplies, and the administrative care for them as well. When these patients get cared for in a facility such as a hospital or a surgery center, things are billed out a little bit differently than the way we bill out. So the anesthesia provider gets to file a claim to the insurance companies known as a professional fee for their anesthesia care. And then the facility also gets to bill out a facility fee, which covers all the supplies, all the support staff, and all that stuff. When we do this in the dental office setting, all that falls upon our shoulders. And we've worked with the MCOs to help mitigate that, but we have several barriers for us that make care cost prohibitive. So Kansas Department of Health and Environment is well aware of this issue, and they've been trying to work with this as well. So when the patients that have dual eligible special needs plans, that's when we really get it hit hard. Oftentimes, depending on the setting, we may be paying to provide that care because of the reimbursement deficiencies. So we're trying to work towards a means of getting that rectified, and we have two recommendations for you. First, we'd ask that you authorize KDHE to establish a standard billing code for mobile anesthesia in dental office settings at a rate of $2,918 and some change. And this amount mirrors the existing facility fees should these patients have to go to a surgery center or a hospital. Second, we would ask that you endorse qualified anesthesia practices with some criteria of a minimum of having 5 years of performance in office-based anesthesia in Kansas, a patient population comprising of 50% or more of KanCare, Medicare, DSNP recipients in the past 5 years, and active service across at least 10 counties in Kansas. And that's just because we want there to actually be access to care and not just be little hubs of care in the metro areas. Both our group and advanced specialty anesthesia covers all across Kansas in multiple different settings, including FQHCs and state hospitals.
I'm afraid that's your 3 minutes, Jeremy. Thank
Do
you.
you have any questions for me?
We won't take questions at this time. We'll
Okay,
wait and
thank
see
you
if
for
there are
your
any at
time.
the end. Thank you. Next, we have Sarah Pletzman.
Me?
Yes, we can, Sarah.
Hi, thank you for your time. So I'm Sarah Peltzman. I'm the practice manager for Advanced Specialty Anesthesia. We're based in Lawrence, Kansas, and I'm here today on behalf of Jeff Glasgow, the CRNA and owner. He's currently in Salina today and in Southwest Kansas providing sedation. Like Jeremy said, our practice covers the entire state. We provide mobile anesthesia services to dentists who serve KanCare children and special need adults. Last year, Jeff spoke with you about the ongoing crisis in access to dental care for these vulnerable populations. There are just too few dentists willing to accept KanCare and even fewer facilities willing to grant them privileges to treat patients who require sedation. And the hard truth is most dentists will not work with KanCare patients or special needs adults unless deep sedation is available. Unfortunately, KDHE's current position continues to undervalue and underfund this program. The recent claim that adequate funding would require an additional $15 million to the state's budget is misleading. The reality is, if mobile anesthesia providers like Jeff and Jeremy's and Wichita stop providing these services, patients would be sent to hospitals where the cost of KanCare would be significantly higher than what we're asking for. So today we're asking the same as what Jeremy just stated. We're asking that KDHE authorize a standardized code for mobile anesthesia in the dental office setting at a rate of the 29.18, and that rate would mirror the existing facility reimbursement for 1.5 hours of anesthesia provided to KanCare recipients. And same as Jeremy, we ask that you endorse the recommendations for a qualified anesthesia practice, matching what Jeremy just stated and also listed in our testimony. So thank you for your time and the commitment to improving access to care. We appreciate you.
Thank you very much, Sarah. Next, we have Whit Downing and Perry Spencer. Welcome to committee, 3 minutes.
Awesome. Thank you. Good afternoon, Madam Chair and members of the committee. My name is Whit Downing, and I work for the Kansas Council on Developmental Disabilities. Many of you have heard me share my story in past testimony. We've all heard the statistics about the IDD waiver waitlist. We all know about the workforce crisis for the DSPs. Today, what we wanted to do was paint a picture of what waiting looks like, and that's where Perry comes in. Perry's going to share his story. This is his first time providing testimony.
My name is Perry Spencer, and I'm an autistic self-advocate from Peabody, Kansas. I'm passionate about increasing supports for people with developmental disabilities that have co-occurring mental health conditions. I'm currently on the wait list for the Intellectual Developmental Disability Waiver. This is causing lots of difficulties in my day-to-day life and limiting my independence. I may seem like I'm doing well because I can come here and speak with you professionally, but I struggle with daily activities and need support to manage my daily routine. I need lots of help to manage and take my medication regularly. My mom fills up my pill organizer and picks up my medication from the pharmacy. I can't have access to more than a week at a time for safety reasons. I struggle with the steps of preparing food and have skipped meals in the past when my parents are working because the steps are too overwhelming. We have been struggling as a family because I have been in constant crisis with multiple inpatient hospital visits because of lack of support. I need help staying safe as well because I occasionally engage in self-injury when extremely overwhelmed. My parents have to provide all this care currently, and it's causing difficulties with family relationships. I'm getting to an age where it's normal to start pulling away from caregivers. I'm pulling away emotionally but can't pull away physically because of care needs I can't get met anywhere else. I need an outside adult to help me with these things so I can go through the normal process of gaining independence from your parents while still getting my needs met and staying safe. I've had to put lots of my goals on hold because I need support for maintaining them. It feels devastating to wait so long knowing it could be years until I get any help, even though I'm drowning right now. I've already been on the waiting list for 3 years, and I feel numb and apathetic because it's hard to believe that I'll ever get services when I know they will help me so much. If from Peabody.
And our written testimony goes into more detail about other priorities we have too, but we really wanted Perry to have the chance today.
Thank you so much, and thank you, Perry. Next, we have Mike Burgess, and I know Mike might be a little late. There you are. Welcome, Mike.
Thank you very much. So Chair Gossage and members of the committee, it's my distinct pleasure to be here. And for most of you, you've heard some of these themes may sound familiar, obviously not just from previous conferees, but for those of you that were on the special committee, I've pared the list per Chair Carpenter's request a little bit. I know it's still longer than you'd like, but just to very quickly go through them. But essentially, the theme is to fund year 3 of the 5-year plan to eliminate the wait. I think as Perry just illustrated too, you know, we've got to have a multi-year plan. We've got to get there. And I think the good news, the bright side, is we're a lot closer than it would appear on paper. And you've heard some of this before, but just to hit that. So we've got to continue to fund some additional slots on the comprehensive waiver. So the recommendation would be 500 slots there. We want to fund an additional 500 slots on the community support waiver once that is up and going. And those are kind of the 2 key pieces. As we move into kind of the next couple of recommendations down there, this is about how we help handle the wait and change how we prioritize who we're going to serve. And so that way we can make the waiting list a planning tool instead of this a penalty, if that makes sense. And I think there's ways that we can creatively do some of these that don't, you know, we're not, these aren't as high dollar items, but it's going to be a game changer when we really do that. So part of that's just creating a portal for individuals so they have a place where they can go and see where they're at. They can update their information. It's two-way interactive. Ideally, too, it shares the dashboard component of it would make some data available to the public and others so we can better understand the people on the waiting list, where they're at, what part of the state, looking at, you know, high-level demographics, obviously totally, you know, no personally identifiable information out there. Another key piece is we have people that get lost. When you're on the waiting list, I mean, the CDDO does contact you annually. But if you talk to families, I mean, I know you all have, who are on the waiting list, like they're not really sure where they're at. They're not really sure if we're making progress. And so one of the other pieces is we ought to be having the CDDOs for this waiver, and the independent living centers would be a great potential group to do that outreach for the PD waiver and other waivers as well. But to help, you know, do the more of that hands-on, you know, finding out and making sure that people, you know, just checking in more often with them too. So that's another piece. And then the last piece is we are so close to this, you know, human behavior has changed. The waiting list was so long, people are signing up early. Well, this ought to be a great thing. We want them to sign up early, but we need a good way to triage and prioritize that. And so some states do this, such as Virginia, and so they break it down into when you need services as a component. And this will be a big change to the way we've done it before, but the first step to be able to make that transition would be to convene a stakeholder group to have the discussion and come up with a Kansas way of doing that. And that doesn't have to be hard, and we could possibly work with the council and others to make that happen.
Mike, that's our 3
You can
minutes.
see my last two things there, and I'd be happy to stand for questions at the appropriate time.
Thank you so much. Next, we have Tanya with oral health. Welcome, Tanya.
Thank you. It's an honor to be with you all this afternoon. It's good to see you, Madam Chair. Again, my name is Tanya Dorfbruner. I'm the Executive Director at Oral Health Kansas. We're the state's oral health consumer advocacy organization. I'm going to start with something I don't usually do, and I'm going to tell you a story. I usually kind of go into facts. You've got a lot of facts in my testimony, but I want to start with a story. 14 years ago, there was a 24-year-old single dad, and his name was Kyle Willis. He had a toothache, and it was really bad. He was a student, and he didn't have health insurance because he was a student. The toothache was so painful that he ended up going to the emergency room. There he got a prescription for pain medicine and antibiotics. They recommended he go to a dentist, but he could only afford the pain medicine, which is probably what most of us would do if you could only afford one thing. So he just worked on trying to get out of pain, and he waited. I don't know if you've ever had a toothache, but if you have to wait, it's kind of all-consuming. But it's extra all-consuming if you also don't have money to take care of what your need is. So there is no backup plan. You know, if you can't afford to go to a dentist, there's no backup plan. So Kyle was busy taking care of his 6-year-old daughter. He was busy studying. He was living in pain, and he was worrying about what would happen next. After 2 weeks, the infection in his tooth went to his brain, and he died. He left his little girl without a dad. Did you know you could die from a toothache? I didn't know that until I started this work, and I don't think Kyle knew that. So in recent years, we in this room have had a lot of discussions about oral health, and I'm grateful for all of those. You all know very well oral health impacts overall health. People who have dental disease face exacerbated rates of heart disease, diabetes, even a higher risk of poor pregnancy outcomes. Infections can also spread to other systems, and that's exactly what happened with Kyle. His story is kind of well known in our community because it received a lot of media attention, but the truth is this kind of thing happens a lot more often than we know. But because of your detailed study of this issue, you also all know that adults and kids who access dental care are able to thrive in the workplace, they're able to thrive in school, and they can support their families and their communities. So your recent investment this year, in adult dental coverage over the last few years, but also in the rate increase this year means that adults shouldn't have to wait until it's too late to receive care. But they really are still waiting. Even with this rate increase, they really are still waiting because too few dentists are still able to see them. So my testimony has a lot of new data that you haven't seen. It's from 2024. We know that there are only 49 dentists in the state that work in safety net clinics, only 49. That's not nearly enough to meet the Medicaid dental needs here. So the rate increase you did pass this year was a massive step forward. I can't thank you enough. One dentist recently told us she was pleasantly surprised to see the new rates. She said she has actually since applied to become a Medicaid provider, and that's thanks to you, and bravo. As you can still see in my testimony, I've got a lot of quotes in my testimony from dentists. They're really pleased with the rates, but they still have some concerns as small business owners and as providers that needs to have rates at a level that will actually cover the cost of providing care. So we're in the process right now of forming another advocacy coalition of providers and advocates to support the job on finishing the rates on the rate increase. 20 groups have joined so far. I'll be sharing that list as it grows a little bit. So as you prepare the recommendations for the 2026 legislature, we ask you to make a recommendation to complete that Medicaid dental rate increase to a $30 million all funds. And if my math is right from this morning, it's about 11.1 million SGF.
Tanya, I'm afraid that's your time, but I
That's
think
all I
you're
have.
right there. Well done. Next, we have Colin Olenek. Welcome to committee, Colin.
Thank you all. Thank you for your time. You've all heard about the waiting list and capacity needs. I added that in. And we do have one concern here that I did want to bring forth. Zach is a member of the Kansas Advocates Network, or KanCare Advocates Network, and we are concerned about the state potentially eliminating the autism waiver. And we were just wondering, what is the status of that? And if they are getting rid of it, what will happen to those people who are eligible for it? And I will stand for questions at the appropriate time.
Thank you, Colin. Next, we will go to Daniel Goodman.
Good afternoon. Dan Goodman, Kansas Advocates for Better Care. Thank you for the opportunity to speak and support long-term care services for older Kansans. First, I'd urge you to support additional funding for the HCBS Frail Elderly Waiver. Projected shortfalls of $28 million in FY26, $70 million in FY27 threaten access to vital in-home support. A wait list potentially beginning this fall could leave 600 frail elderly without needed support. And the effects of such waiting lists have cascading consequences to many of those other than the initial 600 affected. Kansas already ranks 47th in the nation for low care residents in nursing facilities. A wait list could only worsen this ranking and lead to avoidable declines in health for older Kansans. Kansans who simply need this service to remain in their home. Last session, the legislature added $200 million in annual base funding for nursing facilities. An investment in home and community-based care is both reasonable and cost-effective. If a wait list cannot be avoided, we recommend using the already funded $20 million community care coordination service that's already included in KanCare, the current KanCare contract. That's a lot of Ks or Cs. This service, 10 months in, is not yet implemented and could really help with folks waiting on the wait list. If you remember, Frail Elderly Waiver does not have current case management support like other waivers. So why not put community care coordination to work and support older Kansans waiting for help? Second, Kansas should address workforce shortages by adopting innovative models used in other states, such as New Mexico's Competitive Pay for Professionals grant, which raises baseline wages, attracts new workers, reduces turnover, and improves overall quality of services. Kansas could create a similar program for home health agencies and nursing facilities by targeting incentives to areas with the greatest benefit because of staff shortages, requiring providers to meet minimum pay standards to qualify, and adjusting Medicaid and state reimbursement rates to reflect real care costs and competitive wages. These actions would strengthen our care system, support family caregivers, and allow Kansans to age with dignity in their own homes. Thank you for your time.
Thank you very much. Next, we have Stephanie Sanford.
Thank you for calling me up. I want to make it very clear that I'm not representing an organization or a group. I am speaking as a lifelong Kansan with a disability, born and raised in Coffeyville. Shout out to Representative Bryce. Currently living in Lawrence. Shout out to Representative Ballard. In the middle of that, I worked at Hutchinson at Prairie Independent Living Resource Center. And I had the honor of working with and alongside Representative Bethell. And when I look at the committee, I realized that only 3 committee members had the opportunity to know him and work with him. Do I have a story to tell you? When he first came to the legislature, he was a nursing home administrator, still was. And he was not very fond of home and community-based services at the very beginning. And it was our job as Centers for Independent Living to reach out to representatives to gain their support. And it didn't happen overnight, I promise you. But I don't know what time it was and what exact date it was. He changed. And we had all kinds of PowerPoints, all kinds of demographics. And when he realized that nursing home care, and thank you, Mr. Goodman, for giving me a great lead in, when he realized that nursing home care was twice as expensive as home and community-based services, well, the light came on. And he became a champion for home and community-based services. That's why your committee bears his name. And I don't know if you really appreciate the legacy that you serve under. He became the champion because he realized that this was the dignified and financially responsible choice to make. I was going to end with a story about how we met, or how the last time I saw him. But I have some things that are really heavy on my heart from the last week. And very quickly, I just want to say that this year, this legislative session, you have met 4 times. Only 2 of those times did you allow private citizen comments. I believe had Representative Bethell been chairing this committee, that wouldn't have happened. And I think it's a dangerous precedent. Second thing were a couple of, and I don't know how to categorize them except to say that they were accusatory questions. Ron, I've got to address the comment about illegal immigrants and their impact on measles, because it took me less than a minute to find the answer. 80% of people who had measles in Kansas were under the age of 18. 90% were unvaccinated, and 100% were white. It was white Kansans who were undocumented or who were unvaccinated who brought the measles epidemic to Kansas. You can read the other statement. It was about Representative Peck commenting that maybe seniors were abusive in their CHAMPS program, which is utterly ridiculous.
Thank you so much.
5 levels of oversight.
It's refreshing to have somebody just speak to us and not read their testimony when we have it right in
I
front
left it at home, but you know what? I was a debate coach.
Thank you so
I taught
much.
speech, so.
Thank you, Stephanie. Next, we have Heather Brom.
I'm going to move this. Let's see here. Is this still on? Am I still good? Okay. Chair Gossage, Vice Chair Carpenter, and members of the committee, thank you for the opportunity to speak this afternoon. My name is Heather Brom, and I am the Senior Policy Advisor with Kansas Action for Children. And I am here once again to ask that you include in your recommendations to the 2026 legislature support of our continued request to permanently fix now a nearly 18-year and counting error with the Children's Health Insurance Program, or CHIP, eligibility threshold. I know you guys are tired of hearing me talk about this, but I'm stubborn. Kids' health depends on regular access to quality care, which includes health insurance coverage covering important time-sensitive services like doctor and dentist visits, immunizations, therapies, prescriptions, and hospital stays. Up to a certain income limit, CHIP coverage is available for children in Kansas families whose household income is too high to qualify for Medicaid, and who aren't offered child insurance coverage through a job, or they can't afford health insurance coverage for children on their own. According to current state law, so in statute right now, Kansas children qualify for CHIP if their family's income is less than 250% of the 2008 federal poverty level. As a result, through early 2022, the state annually converted that eligibility level back to those 2008 numbers. The converted percentage had declined to 225% by 2021, and you can find a chart of that erosion in our testimony. Since 2022, the legislature has passed several annual budget provisos temporarily fixing that and ignoring that 2008 year reference in state law. But we still need a permanent fix, as well as a need to remove language regarding waiting and lockout periods, which are no longer allowed under federal regulation. During the 2025 session, the House overwhelmingly passed legislation. We thank Representative Carpenter for his leadership on that. Senate Bill 126 that addressed these issues, but unfortunately this language was removed at the last minute during conference committee negotiations. We hope that discussions will continue into next year to permanently address this issue, and that the Senate will also pass the same language that passed the House, and that's currently sitting in their chamber as Senate Bill 271. CHIP has connected thousands of Kansas kids to insurance coverage each year over the past several decades. And so we urge this committee again to include in their recommendations their support of permanently fixing this issue, especially as we learned last month that over 50,000 Kansas kids are now uninsured as of last year, a significant increase year over year. We should be seeking solutions like this CHIP eligibility fix to guarantee more Kansas kids are insured, not less. Thank you for this opportunity, and I'll stand for questions at the appropriate time.
Thank you very much, Heather. Next, we have Marissa Alcantar. Welcome.
Thank you. Thank you so much. Thank you. Hi, Madam Chair and members of the committee. Thank you for the opportunity to provide testimony today. My name is Marissa Alcantar. I'm the Policy and Advocacy Manager for the Alliance for Healthy Kansas. The Alliance is a nonprofit, nonpartisan organization, and we represent a statewide coalition whose goal is to improve health for all Kansans. Our lead policy priority is to increase affordable health coverage for low-income Kansans through Medicaid expansion. In July, Congress passed legislation that will result in large-scale spending reductions in the Medicaid program. These are the largest spending reductions in the program's history and will significantly impact the program over the next decade. These provisions for the Medicaid program were just too rushed, and with healthcare costs on the rise, Kansans need help right now, not reductions. The Alliance also wants to express its concerns about the legislation and the impact it will have on the state itself. Federal spending reductions will have an impact on the state's budget and could prevent Kansas from achieving all of its priorities. In addition to this legislation, there has been no movement at the congressional level to extend the enhanced premium tax credits on the ACA marketplace. The end of these enhanced tax credits will directly impact Kansans that get their health insurance through the marketplace, and estimates are showing right now that this will significantly increase premium costs for the average enrollee, making it even harder for Kansans to access the care that they need. Positive work that Kansas could be working on right now is Medicaid expansion. This will allow low-income working Kansans to access health coverage, helping them to get the care that they need, all the while supporting our hospitals, our communities, and our economy. Thank you so much for your time today, committee. Madam Chair.
Thank you. I just want to note that in their report to us, it was reported that we will receive 1.83% more federal funding for our Medicaid program. Now we will go to Megan Shreve.
Good afternoon, Chair, members of the committee. My name is Megan Shreve, and I'm the Executive Director of InterHab, representing nearly 50 community-based providers across Kansas who support individuals with intellectual and developmental disabilities. First, I want to sincerely thank you for your continued engagement and commitment to supporting Kansans with IDD. Your ongoing work has strengthened services and created momentum for the people and the families that we all serve. Our progress depends on continued collaboration between providers, families and individuals, stakeholders, and you, the legislature. InterHab recently released our 2026 Roadmap for Modernization, a member-driven guide to help Kansas modernize the system while protecting what matters most: choice, quality, and local connection. The guide was built with the future in mind and emphasizes that modernization will only succeed if it's paired with clear guidance, realistic timelines, and adequate resources. You continue to hear that across every area of the system, from case management to the waiting list to direct services, capacity remains our most pressing challenge and our greatest opportunity. We must build the workforce and infrastructure needed to deliver high-quality services while ensuring Kansans have timely access to the supports they need. Modernization efforts must be phased, data-driven, and capacity-informed, allowing providers to expand thoughtfully without disrupting the trusted relationships families rely on. The same workforce that supports individuals today will be asked to meet the growing needs tomorrow. Without targeted investment in rates and workforce development, Kansas risks expanding eligibility without the people needed to deliver services. That's why our roadmap calls for sustained rate growth, stronger collaboration to recruit and retain direct support professionals, while allowing flexibilities to uniquely address all the areas of our state. We recognize that all of the transitions are unfolding at once, and each carries its own set of demands, and together they test the limits of providers and the state as well as workforce capacity. We must ensure that these changes move forward in coordination with the MCOs reinvesting promised dollars and the state supporting provider rates through the period of transition. We believe that modernization gives Kansas the chance to strengthen our IDD network when stakeholders work collaboratively and funding supports priorities. Thank you for your time, and I'm happy to answer questions.
Thank you very much, Megan. Next, we have Sean Gatewood.
Thank you, Madam Chair, members of the committee. Some of my thunder's already been stolen. I have to say thank you to Chairman Carpenter earlier for his comments on the FE waiver. The last time I was up here, I talked a little bit about who those populations are: the FE, the BI, and the technical assistance waivers. So I think we all kind of have a firm understanding of that. But just as a reminder about waivers in general, we kind of think of those sort of the wrong way around. Because it comes from the federal government, it's a little bit backwards. So you have the right to, the folks that are on those waivers, you have the right to institutional care. You're literally waiving that right? So that you can live, in your own home, age in place, live with a disability in the community, among others. Instead of, I believe we need to be looking at those as more that the individual has the right to maintain the highest degree of freedom and individual liberty to live in the community as long as possible. And then have to go into the nursing home if you have to, if I'm making this make sense at all, that it ought to be the first thing we do is to try to keep people in their homes, in the community, living the best life that they can. And so that's why those waivers are there, not to mention the BI waiver is rehabilitative. So again, in every regard, all of those waivers save the state money by keeping people out of more expensive institutional care and lead them to living the best life that they possibly can. So I'm just here to kind of sound the alarm again. I know it was already kind of done today about the impending wait list on those 3 waivers. And I will stand for questions at the appropriate time. Thank you very much.
Thank you, Sean. And now we have Hal Oberholzer. Welcome, Hal.
Thank you, Chair Gossage and committee members. My name is Hal Oberholzer, and I work for Maxim Healthcare Services as the Market Development Manager throughout the state of Kansas. Maxim is a provider of specialized medical care through home and community-based waivers, the TA and IDD waiver, which is the acute care facility equivalent or the facility equivalent of an acute care facility. These services are critical to Kansas's most medically complex patients. Typically, these patients receive nursing services in their home anywhere from 8 hours a day up to 24 hours per day. I'm here today to thank the governor, KDADS, KDHE, and especially this committee for their investment in specialized medical care. This year, the program received a $5 rate reimbursement increase. Thank you, and we're very grateful to utilize these funds to expand this program. I am also excited to announce that according to Cora data, it shows the program provided the most hours ever for specialized medical care in 2024. A major reason for this increase is due to the investment the state has made in this program. Maxim has utilized these funds to significantly increase our nurses' direct pay through wage increases, bonuses, and PTO programs. The rate increases from the state are going directly to our nurses, which has allowed us to better recruit and retain nurses, which in turn has allowed us to provide more hours and more services. Maxim and the provider network look forward to continuing to expand this critical waiver service. Thank you, and I'll stand for questions.
Thank you very much, Hal. Next, we have Ryan Jolly.
Hello. It's going to be hard for me to cut it to 3 minutes. So in my written testimony, I say really nice things about you guys in the last time we were here. Shout out to Senator Owens, who said that caring for individuals who rely on home and community-based services is, quote, an incredibly important function of government. I'm here representing Little Lobbyists. We're a group of Kansas families from all over the state that have come together to advocate for our disabled children. And in committee rooms like this, where the broad strokes of policy are being discussed, the life of the individual can often be overlooked. So today I'm going to tell you a story about one family and one child, my family and my child. I've been a foster parent for 16 years. I've cared for over 50 children in the custody of the state, and I've come to specialize in children with high medical needs. I've adopted 3 of those children. My 4th child is my youngest, Bob. That's not his real name. I give him a pseudonym because he's one of the roughly 25 children in state custody that rely on the TA waiver. He relies on the one-on-one nursing care that only the TA waiver provides. When Bob was 16 months old, he was assaulted, and he experienced a catastrophic brain injury, multiple skull fractures, spinal cord injury. He was left nearly blind, nonverbal, cognitively impaired, and quadriplegic. He's dependent in every way. At the moment of that assault, like that, he was reduced to infancy for the rest of his life. Bob came to us. I got the call to take Bob, and he had a life expectancy of 6 to 8 weeks. The doctors told us there were only 2 options for Bob. He would either die peacefully in our home, or I would be unable to provide his basic care, and he would go back to the hospital to die there. But those doctors were wrong. Next month, we'll celebrate Bob's entry into our family, his jolly-versary, if you will. Next month, he will have been with us for 7 years. How did Bob defy the doctor's predictions? Home and community-based services. HBCS services, and most importantly, that in-home nursing care, have allowed him to receive the high-quality medical care that he requires while cradled in the warm embrace of a loving family. That is only possible through KanCare and the TA waiver because in-home nursing care is not available through any commercial insurance plan. Our journey as a family with Bob has not been an easy one. I can't tell you how many ER visits, ambulance rides, and surgeries he's had, or how many sleepless nights I've spent at his hospital bedside or in the hospital chapel. What I can tell you with absolute certainty is that had he been relegated to life in that hospital bed, he would not be here today. Those doctors would have been right. The loving home that we have been able to provide for Bob is only possible to us because of home and community-based services. Without it, I would never have been able to say yes to that initial call to care for him, and I would not be able to say yes day after day, year after year.
Thank you so much for your testimony. And next we have Tanya Hammett, who's virtual. Is Tanya on with us? She's there. Tanya, can you hear us? Maybe you need to unmute.
She states she's unable to unmute.
Can you hear me now?
Yes, we can.
Okay, thank you. Good afternoon, Madam Chair and committee members. I am Tanya Hammett. I'm representing National Seating and Mobility. We are a national supplier of complex rehab technology, otherwise known as CRT. We currently have 2 locations servicing Kansas Medicaid recipients in need of customized power and manual wheelchairs. We appreciate the recent rate increase for repairs from 65 to 80% of Medicare and the passage of SB 125, allowing reimbursement for annual preventative maintenance checks for CRT equipment. The goal of preventative maintenance is to ensure equipment is working properly and repairs due to normal wear and tear are identified before more damage is done, leading to major or emergency repairs and leaving the client without the use of their equipment. As part of the maintenance checks, suppliers complete a 19-point safety inspection and make standard equipment adjustments while identifying any replacement or worn parts that are needed. Providing replacement parts identified during the maintenance check must be eligible to be performed the same day, billed and reimbursed separately. We ask the committee to instruct KDHE to provide clarification that identified repairs and labor be billable on the same date as the preventative maintenance check and as intended, so anticipated repairs are done before they are dire or catastrophic. The established rate for the annual preventative maintenance check is $76.04 per hour. This rate does not support work performed at the client's home. While performing repairs and maintenance in our office is more successful due to access to more parts and tools, many Medicaid recipients do not have the means to travel to supplier locations. They require us to come to their home. We urge the committee to instruct KDHE to work with us to establish reimbursement guidelines for clients unable to come to supplier locations. One possible solution is to compensate suppliers for travel time. KDHE published guidance indicating a prescription may not be required for CRT repairs, but must be submitted if requested by Kansas Medicaid. We ask the committee to instruct KDHE to remove the ambiguous and redundant documentation requirements for CRT repairs. Medical necessity and lifetime need is established at initial provision of the equipment. Suppliers submit medical justification along with a physician chart note and mobility evaluation with the new equipment prior authorization request. Once the equipment is approved, delivered, and claim paid, there should be no reason to submit additional documentation for replacement parts. NSM and the other CRT suppliers providing testimony are open to working with KDHE and this committee to ensure timely access to repairs and minimizing wheelchair downtime for users of this technology. Thank you for your time and consideration.
Thank you so much, Tanya. And next we have Melissa, and Melissa is also virtual.
Hello, I would like to take time to thank the committee for the opportunity to present the testimony today. I am a physical therapist and assistive technology professional with 28 years of experience, focusing on patients with complex neuromotor conditions and the most current evidence-based care for the assessment, recommendation, and authorization of funding for complex rehab equipment. The last 3 years, I have been the national sales manager and clinical educator for Adaptive Imports, the U.S. distributor for several pediatric complex rehab equipment manufacturers. My recommendations today refer specifically to the comments regarding pediatric transport strollers and growth requirements for wheelchairs. I agree that strollers are commercial products and not DME, but pediatric transport stroller is not a valid description for products that are confirmed by the FDA as medical devices and appropriately code verified by PDAC as wheelchairs. Wheelchair products are automatically being denied as strollers when they are appropriately verified by PDAC wheelchair coding E1231 to E1238. It is recommended that this statement be amended to support and acknowledge these pediatric-sized products are wheelchairs and that they meet the funding criteria for the appropriate PDAC-verified codes. The requirements for growth potential for wheelchairs currently refers to growth in the wheelchair frame only, but the seating system needs to be considered here as well. There are wheelchairs with non-adjustable bases that accommodate the mounting of a seating system that provides the growth and adjustments, not the frame itself. The prescription for wheelchair adjustability and growth is specific to the independent or dependent needs of the client. Independent needs require specific alignment and configuration for optimal support and access to independent function and inhibit risk of injury. Dependent mobility needs require more focus on adjustable seating and not specifically the growth for the base that is being pushed by the caregiver. Additionally, it is not always necessary to consider substantial growth for someone over 18 years of age, regardless of independent or dependent needs. This young adult is approaching the end of developmental growth spurts. The management of postural, medical, and functional needs, as well as weight control, guide the recommendation of wheelchair seating and frame needs and that adjustability that might be needed. It is recommended that the statements referring to members under 12 years of age and members 13 to 17 years of age be amended to state the wheelchair frame and or seating must accommodate growth potential, not just the frame, as well as the possible removal of the statement for those 18 years of age and older, or amended to read, wheelchair frame and or seating must accommodate growth potential. I'm not sure if you can see, but I do have a sample of the Hoagie Bingo Tilt Space wheelchair system, size 2, that is PDAC coded appropriately E1234 and has lots of adjustability as mentioned within the recommendations of the code if those modification or recommendation changes are made. I will be available for questions as needed. Thank you.
Thank you so much. And next we have Ted Malkowski from New Motion. Welcome, Ted.
Thank you. How about now? All right. Good afternoon. My name is Ted Malkowski, as you said, from New Motion. We are a national complex rehab technology company, also known as CRT. We have 3 locations that serve individuals who need this advanced equipment to remain in their homes and provide mobility in the state of Kansas. The equipment is provided and medically justified in a collaboration with a comprehensive team that includes the doctor, the therapist, and the ATP provider, which I am one of those. First, I'd like to address the new KMAP policy outline in the new General Bulletin 25201 and the guidance. Providers in the state of Kansas, such as New Motion, requested to be part of the conversation in developing this new policy. We also asked that clinicians from certified seating clinics and other doctors help craft the policies. This was discussed with both KMAP and MCO representatives, and our efforts were declined. They said they had enough people to work on the policy without having industry involved. Unfortunately, there are many concerns with access issues of the new policy. You've already heard a couple, and you will hear more to come. Hopefully, in the future, the industry can be involved in creating the policies that affect the individuals we serve. I'd also like to thank legislation for passing SB 125 last session, and like to address a few issues in the language in implementing the bill. The proviso passed states prior authorization repairs of complex wheelchairs not required. It's also important to note that in order for repair to be performed, timely eliminating prescription and prior authorization requirements for CRT wheelchair repairs allow the provider to fix the wheelchair with parts on hand in one appointment, reducing unnecessary repeated appointments and travel, potentially reducing the costs to the state by getting members back in their medically appropriate piece of equipment that prevent pressure sores, or adding caregivers that they may need to help with their daily activities. We've seen similar legislation passed in other states, Tennessee, Wisconsin, and Colorado, to name a few. We've seen dramatic reduction in the amount of days the member was without their mobility equipment. We would like to respectfully respond to concerns that removing prior authorization and prescription requirements for repairs exposes the state to fraud and abuse. We have seen this in other states, and there are provisions in place to prevent it. We have not seen this in other states, I'm sorry. And there are many provisions to prevent it from happening. In the legislation proviso alone, it says that the Inspector General will do a post-review audit in 2026 of all wheelchair annual preventative maintenance as well as all complex wheelchair repairs. So this is something that will easily monitor it. Also, in the KMAP policy, there are several additions to help to make sure that there is no fraud and abuse in this prevention. It says, addition of new equipment or options, accessories are not covered. Member repair of rental equipment, not covered. Repair equipment not covered by warranty due to abuse or neglect, not covered. Repairs that cannot exceed 75% of the cost of a new equipment, not covered. So there's a lot of different things placed in place to make sure fraud and abuse does not occur by eliminating this prior auth. Having all these requirements placed will prevent any fraud and abuse and will in turn allow Medicaid members to get CRT equipment fixed timely and accurately so they can get back to living their lives. Thank you.
Thank you so much. Couldn't have been timed better. Next, we have Julie Piriano. And she is virtual. Is she ready? Okay. Julie, if you can hear me, if you could push your mute button. I think you're muted right now. To unmute.
I'm trying. There, can you hear me?
Yes, we can. We can hear you now. Go ahead.
Chairwoman and committee members. My name is Julie Piriano. I'm a physical therapist and assistive technology professional and seating and mobility specialist with 41 years of experience in the industry. I'm also currently the Senior Director of Payer Relations and Regulatory Affairs for NCART, the National Coalition for Assistive and Rehab Technology. We are a national nonprofit association of manufacturers and suppliers of CRT who focus on establishing and protecting appropriate coding, coverage, and payment policies to ensure children and adults with disabilities have access to the specialized equipment and related supporting services that they require to participate in life's activities in their home and community. I'm here to highlight two coverage exclusions in the policy that we feel constitute a violation of the federal mandate prohibiting an absolute exclusion of coverage for medical equipment, is contrary to current Kansas Medicaid policy listed on page 8-9, and creates a health inequity for Kansas Medicaid beneficiaries. On page 8-84, it states that power elevating leg rests are not covered. This is a huge issue for members with disabilities that require the mechanical means to change the position of their legs in a power wheelchair, especially when they use other power seating functions. We respectfully request that the non-covered verbiage be removed from the policy and permit coverage if the beneficiary has a medical need for leg elevation and is unable to operate a manual elevating leg rest system. The second device, deemed DME with the release of the national coverage determination for it on May 16, 2023, is for power seat elevation systems. Power elevating wheelchairs are listed as non-covered on both pages 8-86 and 8-89, even though KMAP General Bulletin 24073 states that HCPC code E2298, a complex rehabilitative power wheelchair accessory power seat elevation system, is covered effective April 1st, 2024. Power seat elevation doubles the functionality of the power wheelchair as it allows the beneficiary to independently adjust the height of their seat to safely transfer to and from the chair or reach and function within the vertical environment. The NCD lists specific coverage criteria that we respectfully request Kansas Medicaid adopt to ensure members have the same access to this technology as beneficiaries covered under other federally funded healthcare programs. Thank you so much for your time and consideration, and I look forward to any questions you may have at the appropriate time.
Thank you, Julie. And next, we'll turn our attention to Scott Lopez.
Good afternoon, Madam Chair. Good to see everybody again. My name is Scott Lopez. I'm an occupational therapist, assistive technology professional, and a certified rehab technology supplier. I've been serving and providing support to individuals with disabilities for more than 30 years now. Today, I want to talk about a couple things. You heard Ted talk and Julie talk. I'm not going to repeat everything they said. You have my testimony. But I really think it's time for the state to establish a DME subcommittee. And this DME subcommittee should be made up of clinicians, beneficiaries, their family members, the DME suppliers, the MCOs, KDHE, and ideally one of you. This way we could work on policy, work on coverage criteria, and work together so we're not spending a lot of time here at these testimonies where you guys could be doing other work. Recently with the new wheelchair criteria that came out, the MCOs made that criteria without any other stakeholder involvement. As an occupational therapist who works for a DME supplier, I am not allowed to get an order from a doctor, go out and see a client, do all the medical documentation without the support of another clinical team. That would be not right. When the MCOs are making coverage criteria without the consideration of the stakeholders involved, we are at risk of missing things or not covering items that these individuals require. I'm going to shift gears now and tell you guys a little bit of a story that you don't know about me. In May 18th, 2024, my son in downtown Kansas City, Missouri was shot 7 times. His femur was shattered. He got shot in the right knee. He grabbed the assailant's gun and almost severed his thumb. He was in the hospital. They took him to Truman. They did a great job with the trauma surgeons. And he was in the hospital for a week, and then he had to come home to his mother and I. He works for Alliance Rehab. He was a technician. So I had to go to work every day, do a little bit of double duty, do my job, do his job, take care of our clients. And then I had to come home and take care of my son and relieve my wife because she was exhausted. And I'm going to tell you something. It's exhausting work. These families, they don't have any additional time. They're tired. They're trying to care for their children. You know, we heard Miss Ryan over here speak, Miss Ryan Jolly speak about her day. These families don't have any additional time to advocate for their children, to make sure the rules are right. So I think if we form this DME subcommittee, it gives us the opportunity to finally get it right, to do the right thing and have all the stakeholders involved, to make sure that we're coding wheelchairs correctly, that we're doing service and repair correctly, that we're doing all the right things for these individuals that require our services. I appreciate your time. I appreciate your commitment for what you do for these Kansans with disability, and I will take questions when you're ready. Thank you.
Scott, thank you for being here. Next, we have Robert Cooper. And Robert, you'll be saying something other than what was said by Ted, right?
Correct.
Good.
Thank you, Chairman Gossage, Vice Chair Carpenter, and committee members. My name is Robert Cooper, and I've been an assistive technology professional, an ATP, since 2001, currently serving Kansas Medicaid beneficiaries with new motion out of our Kansas City branch. I'm here today to talk about 3 coverage restrictions in the current policy that are significantly limiting access to medically necessary CRT for children and adults with disabilities. The first issue, which is new as of the August update, is the coverage criteria for power seating functions, specifically power tilt and power recline, on page 8-88. Let me explain. You are sitting here and listening to our testimonies. Can you imagine if you were unable to change your position whenever you needed to, for as long as you wanted to, and then change it again and again throughout the 12 to 18 hours that you'll be sitting in your chair every day? Power tilt, rotation in space, allows you to maintain your seated position as your seating system rotates backwards to provide stability against gravity, shift pressure from your seat to your back, support your head and neck for improved breathing, chewing and swallowing, and a host of other reasons supported by peer-reviewed research. Power recline, on the other hand, typically used in conjunction with power elevating leg rest, allows you to move your joints, stretch your muscles, eliminate pinch points for improved circulation, redistribute your weight over a larger surface area, and a number of other reasons which are also supported by peer-reviewed research. We're extremely concerned with the restrictive coverage criteria for these power seat functions in policy, are respectfully requesting the language be rescinded and revised to meet the needs of Kansas Medicaid beneficiaries. Second is the criteria for manual elevating leg rests. We appreciate the August update on page 8-86, which allows coverage to manage swelling in the legs. But this does not allow coverage for people who have a wheelchair with a reclining back or insufficient range of motion in their legs to use standard footrests. We ask the criteria to be updated to include these reasons as well. Lastly, we are concerned about the criteria for headrests on page 8-73, which only allows for coverage with wheelchairs that tilt and for people with complete lack of head control. It does not allow coverage of a wheelchair that reclines for people who need it for positioning or to safely transport beneficiaries who sit in their wheelchair in a moving vehicle. We respectfully request this criteria be updated to permit coverage in these situations as well. Thank you for your time and consideration of this information and for your commitment to improving the lives of the Kansans we serve.
Thank you, Robert. And finally, we have Trista Ferguson.
Hello, committee members. Thank you for having me today. My name is Trista Ferguson. I'm a board-certified behavior analyst and a licensed behavior analyst here in the state of Kansas. I have a unique perspective as I am also a mother of a child with autism. I'm a service provider that is the director of Perfect Fit Therapy Clinic in Dodge City, and I'm the founder of that organization because there were not services for children with autism in our local area in the applied behavioral analysis world. I'm here today to address a few things, but first I need to deviate a little bit because I've been hearing a lot of testimony on the IDD waiver, and I would like to also just pipe in a little bit on that because my son just got the call 2 weeks ago that he is off the waiver, or he is on the waiver and off the wait list. It's been 10 years. So that is absolutely a testimony that I would love for all of you to hear if there is one that you can hear. It's been 10 years. So I can only imagine what other folks are going through when they have to continue waiting. The things that I would like to address with you today are some of the issues that service providers in our world are facing with the managed care organizations. First and foremost, provider credentialing has become astronomically difficult to make it happen. While KanCare is telling us, yes, everything is fine and you are ready to go and provide to kiddos, what we're seeing is the MCOs all have a different process. This one wants one thing while this one wants another. And even though the state is telling us you're good, we are still delayed by what the MCOs are telling us that they need more of. Because of that, kids are sitting on service providers' wait lists and are unable to get the services that they need. The second thing is inconsistencies across authorizations. Yes, we understand that we need to have an authorization for services, but what's happening is wait times are getting longer and longer and longer. And what that means is that children still sitting on wait lists. All we hear about these days are wait lists. There weren't services in Southwest Kansas prior to my organization, and it's very detrimental when families call and say, we're ready for services, and I have to say, yet again, there's a wait list because insurances are not allowing us in a timely fashion to get those kiddos credentialed and authorized. Another problem that we're facing is the limited number of hours that are being able to be billed for the services that we provide, specifically across the assessment portal. What's happening is we ask for 15 to 20 hours and we're denied, telling us we can have 6 to 8, sometimes 10, except they are wanting a lengthy process of assessment, just like was spoken of earlier. And if we are not giving that assessment, we don't get the full picture of the type of service that our client needs. So because of that, they're not getting proper quality of care. And finally, school-based services. It's a natural progression to maintain what we provide. I would love to take any questions that you might have when the time is right. Thank you.
Very good. Thank you so much. Committee, I draw your attention to the 22 pieces of written-only testimony that we received. Also, the minutes were distributed to you for quarters 1, 2, and 3. Are there any edits to those minutes? Seeing none, do I hear a motion to approve the minutes? Senator Erickson, a second from Representative Sutton. All in favor say aye. Committee, we are adjourned until tomorrow at 8:30. Thank you to all the conferees.